at a hearing to provide an update on the city's actions in response to COVID-19. Here to speak on the item are the following: Commissioner of Public Health, Dr. Allison Arwani. Dr. Arwani, are you present? I see you right there. Good morning, doctor. How are you today?
Good morning. Thank you, Chairman Sawyer.
The floor is yours.
Thank you. And thanks everybody for joining. We've been getting a lot of questions from you, primarily related to vaccine. So my goal is to give you just a very quick high level of where we are with COVID, and then spend most of the time addressing your vaccine questions. Hopefully have plenty of time. So I'm going to share my screen, and we will send these slides around.
Doctor.
Yes.
Before we get started, I see that Alderman Hopkins' hand is raised, and I'm assuming it's for the prior item. If we can go back 1 second.
Sure.
Is that correct, Alderman Hopkins?
Yeah, thank you, Mr. Chairman. Actually, no, I just had a question for the doctor.
Oh, I'm sorry. Never mind. Thank
But
you.
regarding the other ordinance, it is my intention to introduce the substitute for the February meeting, sir. Thank you.
Thank you. All right. Thank you very much. I apologize, Dr. Arwani. Proceed.
No, not a problem. And first, I just really want to thank so many of you that have been reaching out, wanting to make sure you have the right information for your constituents. You all know Alfonso Martel at this point, I think. He is our IGA person dedicated to the Chicago Department of Public Health. So we've been answering your questions one-off, but really, you know, if one person has a question, I know a lot of you do. And so continue to please send questions through Alfonso. We see a very high priority on getting your questions answered so that you can help us communicate what is a complicated topic to Chicago's residents. So just very quickly, as a reminder, all of our vaccination efforts are fitting under Protect Chicago. So everything that you've been hearing about Protect Chicago, whether that's our citywide digital outreach, whether that's our block by block, door by door, knocking and bringing information, all of that, the vaccine is rolling into that same outreach plan. So we can talk more about it, but you'll be seeing everything related to vaccine sort of branded with Protect Chicago, and we encourage you to use some of that with your own community. As hopefully people are coming to know. Very quickly on the travel order, people may have seen yesterday that we simplified the travel guidance because the CDC has updated its travel guidance, and just as more testing is available, we're trying to make this as simple as possible. So as opposed to there was a red level, an orange level, and a yellow level, at this point, basically, only one state is in yellow. Hawaii is the only state in the country that has fewer than 15 cases per 100,000, would be considered to be in very good control. Everywhere else at this point, if people are traveling upon return to Chicago, a 10-day quarantine or the opportunity to get that pre-arrival negative test result within 72 hours. This became a requirement at the international travel yesterday for the U.S. as well, and it's just, again, trying to align. So just wanted you to be aware of that. If you have questions, let me know. Very quickly on where we are for COVID. We are monitoring our post-holiday cases. And if you look at this graph, all of this is, of course, available on the website. The dark blue line represents our 7-day rolling average. You can see what happened after Thanksgiving. We were coming down on cases, then saw it come up and come back down. I expect the same thing to happen here post-December and January. Nothing very concerning in the data, but we see a lot of changes in testing patterns related to the holidays. So these cases have still been on the way up, but a lot of it is related to this holiday. Hardin will know more over the next really few days into early next week where we are, but nothing very concerning. Similarly, here's test positivity. You see that same up and down related to the holidays. We're currently at a 10.3% test positivity. That actually has already started to trend back down as we're seeing testing pick back up, and that is where we are. Of course, for this, our goal ultimately is to get to under 5%. We're making good progress there. To move out of the tier 3 state mitigation is to be under 12%, so we're definitely heading the right way. And then deaths and hospitalizations, both are very much on the decline, as well as emergency department visits. I didn't put it all up here, but just to give you a sense of where we are, we're averaging about 12 deaths per day from COVID-19 in Chicago residents right now. That's down from about 24 per day in early December, and compared to about 50 per day at the peak in the spring. This every day, the data does continue to improve in terms of these severe outcomes. All right, here is high level the vaccine-related questions. We tried to group them that we've been getting from aldermen. A lot of interest in an overview of a timeline on vaccine rollout and projected dates. I'm going to talk to that. A lot of questions about 1B, particularly seniors, state guidance, and essential workers. A lot of questions about logistics, especially for our outpatient healthcare workers. Some questions about long-term care and future vaccination plans. And then a lot of questions from many of you about how to help your constituents help out, which we'll come back to at the end. Wanting to really make sure outpatient clinics are registering to be vaccine providers, that organizations know what to do, how individuals can volunteer, and a question about individual people. So data is all available on the website. Here is what our graph looks like overall. There have been almost 10 million people who have gotten a first dose across the U.S. today. As of today, and that has been increasing nicely. Similarly, you can see in blue here, these are our first doses in Chicago residents that have been administered. Green are our second doses. And this does not include non-Chicago residents vaccinated in Chicago. This is one of the questions we get the most. All of public health always, our COVID tests, everything. We report out on Chicago residents. I'll come back to some more detail here. Here's what our vaccine allocation has looked like, December 13th to the present. That very first week in December, we only got Pfizer vaccine. All of our hospitals began vaccinating within that first week. Then week 2 was when we were able to add in Moderna. Week 3, you can see what's been happening. One of our concerns has been, if you look week by week, the amount of vaccine we've been receiving has actually been decreasing. And this has been a conversation really at the federal level. We've heard just in the last day or two that it sounds like the incoming Biden administration has signaled they are much more likely to send more vaccine. Now the outgoing federal administration is also signaling that. I really want to see actual doses allocated to Chicago to make sure that this is actually coming through. But we're hoping this will open up because both last week and this week we got between 32,000 and 33,000 first doses in Chicago, which is just honestly not enough. And I'll show you why. So the other thing to highlight is that our Moderna doses, which as a reminder, these are the ones that don't require that ultra cold storage. They're the ones that are most appropriate for outpatient settings. You need a freezer. So all of our pharmacies, all of our federally qualified health centers, other medical practices, everybody who's going to be vaccinating for us, Moderna is the more desired vaccine. Hospitals and then the city-run, all city-run operations will continue to use that Pfizer vaccine, and we distribute it and make sure there's no vaccine being wasted at any point. It was a requirement, again, through a federal requirement, to allocate enough vaccine for every staff and resident in long-term care facility programs. And we're using Moderna there. Again, we want to make sure that these have been our highest risk settings, more than a quarter of our deaths here, a lot of cases, very high risk, that there's enough vaccine available. And so you can see most of our Moderna doses have had to be allocated to long-term care, 58,900. And so those are not available for general administration. They'll be used over the next few months. So in the first month, we basically had received just under 100,000 doses of vaccine that are available for allocation here in Chicago, not counting long-term care. And where we look at where we've been, and then I'll go through phases. At this point, 2% of Chicago residents, 1 in 50, have gotten a first dose of vaccine. It's changed a little bit week by week. It's been between 37 and 42, but right now we're at 37% of the doses administered in Chicago have been to non-Chicago residents. That's not a problem. These people work in Chicago, either at long-term care facilities or at our medical facilities, but they don't show up in our Chicago numbers. They're still counted. They're in the state numbers, but just making that point, it's one of the main reasons why people say, why are your numbers not higher? And so you can see administered at Chicago sites, we've had about 73,000 first doses. This is just through the end of last week. And then administered to Chicago residents, about 63,000. Here, looking ahead, is where we are. And I want to help you'll see some asterisks here. Timing depends on vaccine availability and uptake. But I really wanted to talk you through where we are and where we're going. So first, phase 1A, which is what we have been in, includes, there's two main goals here. You can see on the left side, we want to prevent severe COVID outcomes, hospitalizations and deaths, major outbreaks. And then on the right, we want to preserve the functioning of society and really prevent infections. So in 1A, which started in December, continues in January, and will continue through February. These have overlap. Something I want you to understand. On the left side are our residents and staff of congregate settings, and always we prioritize here in terms of highest risk. Started with our long-term care facilities, skilled nursing facilities, assisted living facilities. Now looping in behavioral health residential, developmentally disabled residential, places where people are living in congregate settings for healthcare reasons, can't really leave on their own to get vaccine, and high risk for spread. Very important we get vaccine there. Then on the right side, healthcare workers. Again, we started with our hospital-based healthcare workers. There are more than 105,000 hospital-based healthcare workers in the city of Chicago. Then to non-hospital-based healthcare workers, of which there are about 250,000, and then our community health workers, just to call it out because it's been a question, are very much in there. Our Protect Chicago outreach workers, testers, vaccinating teams. As we move to 1B, and I want to be very clear that the timing of this is completely dependent on vaccine availability and uptake. We absolutely do not want vaccine going unused. As the city of Chicago receives vaccine allocated, we push it out as quickly as we can to our vaccinating partners or use it in our city pods, and I'll show you a graph of this. And then we want to make sure that there's not vaccine sort of quote sitting on shelves. I do want you to understand there's been some confusion between is vaccine being wasted? No vaccine is being wasted, period. This comes, I think, from the point that's been made that once you open a vial of vaccine, like that Pfizer vaccine, it's got 5 doses in it, you have 6 hours to use 5 doses. So it is important that you have 5 people to vaccinate and planning around that. But at the higher level, this vaccine can sit in the freezer for 6 months, just to give you a sense. So there's not at a high level any vaccine that's going to waste in the country, and there's no vaccine even at a micro level going to waste in Chicago. So as we move ahead, 1B is going to be about older Chicagoans. And yes, we are using the state definition of 65 plus, but we will be asking our healthcare providers to help prioritize within that group as much as possible. Looking particularly to people who are over 75, you see we have about 155,000 of them in Chicago, as well as people 65 to 74 with those underlying conditions. We also will continue with our non-healthcare congregate settings, our correctional settings, our homeless shelters, our other residential settings. And then on the right side, this is where we move to frontline essential workers. Correctional workers, first responders, grocery store workers, education, manufacturing, public transit, agriculture, food, and postal workers. I can talk more detail about planning around any of those. There are industry groups that are in process, and in fact, a number of these already have kind of planned what the focus of this is going to be. In terms of timing, so particularly because the federal government is signaling that it sounds like we're going to get more vaccine, I anticipate that probably starting from next week, we will be letting our healthcare providers know that their top priority remains vaccinating 1A, these healthcare workers. The slots are getting just snapped up as soon as we can make them available, but if they have any vaccine that would otherwise be unused, that they would be able to start vaccinating older Chicagoans, but it's got to be their existing patients, and we'll be asking them to do some prioritization there in terms of scheduling, the people who are at highest risk. This does not mean, and I want to be really clear about this, that we're going to have our mass vaccination, our points of dispensing opening to 65 plus. This does not mean that we're going to say sign up for 65 plus, but we will be letting healthcare workers and our healthcare partners start vaccinating older Chicagoans if they have vaccine that would otherwise go unused. And as we see more vaccine coming in, that will hopefully be able to open up fairly quickly. On the frontline essential worker side, there is already work and planning. The correctional workers, for example, we've already started vaccinating the healthcare workers in those settings. That will flow directly into the other correctional workers as vaccine is available. Similarly, first responders, we've already started with our emergency medical services, our paramedics, first with Chicago Fire Department, then with our private EMS providers. That will then move into the EMTs who are within Chicago Fire Department, move through fire, move through police. It'll just continue sort of on like this. Planning for grocery store, education, manufacturing, et cetera, ongoing, and I can answer the questions. But I don't think these frontline essential workers, this is more likely to be starting in February, just to be clear. And we won't be done with 1A. We want to make sure that our outpatient healthcare workers and these congregate settings have appointments scheduled, even if those appointments are in later in January or later in February, as much as possible. But we at no point want to hold back vaccine and make sure that it is going unused. So I do think sooner than expected we'll be able to start having that, but this is going to be a complicated communications message, obviously. And we'll be formally doing a press conference and more material about that tomorrow. And then looking beyond that, phase 1C, a lot of this depends on, do other vaccines get approved? Do we have more available? We actually have good plans for being able to quickly ramp up distribution here as we get more vaccine. But the problem is, if I'm getting 32,000 doses of vaccine a week, right, there's 360 older Chicagoans, hundreds of thousands of frontline essential workers, it's just not enough. So then beginning in 1C, again, might this be March, might it be April, might it be May, that's when it will open broadly to everybody who's an adult with a high-risk medical condition, as well as all other essential workers. And then we are anticipating probably by late spring, early summer, all Chicago residents age 16 plus, and then opening to children when those trials are done and the vaccine is authorized for use. So here is what the distribution channels look like broadly, particularly in 1B. Most of our vaccine is planned to go through those blue dots there. About 90% of the vaccine is planned to be distributed through our healthcare providers. This is how we do flu vaccine. This is how we do regular vaccine. Childhood vaccines. So it will continue to go. The city of Chicago will deliver or have delivered vaccine to hospitals, pharmacies, and outpatient providers. And then in turn, we will be looking to those hospitals and outpatient providers to be helping, especially with seniors. The best place for seniors to get vaccine is with their own healthcare provider, and that would be our most ideal goal. And then the pharmacies will also help with seniors, but we'll be looking to them to do more strike teams. Obviously, they're very focused on our long-term care facilities right now, but we want to be able to bring, for example, strike teams to senior living settings, particularly in parts of Chicago where we're seeing lower uptake, and we can talk some more about that, as well as helping with employer clinics. And there will be some overlap here between outpatient providers and pharmacies in terms of helping to support schools and employer clinics. But we especially want to set up as many points of dispensing, places people can get vaccinated as possible. And then we're really anticipating and this has been a top line from the beginning, that the city-operated sites will be more about bringing vaccine to areas where it's most needed and filling in the gaps. So we will be, and we already have opened what we call our fixed pods, points of dispensing. Right now, that started at Malcolm X for healthcare workers. We're expanding to additional city colleges. There are still a lot of affiliated healthcare workers, workers and physical therapists, etc. Again, we're trying to make sure that these sites are available mostly for the essential workers, especially the ones that might work in more independent settings, and can talk more about that. We have a public safety pod or point of dispensing that's going very well, ramping up really nicely. That will continue. We'll have the opportunity to do some mobile pods, again, down the line a little bit, where we are bringing, again, vaccine for a closed point of dispensing to people who may live in a senior congregate or a senior living situation. We're unlikely to have the resources to be able to do that all over the city, at least initially. Most of that will be looking at where are we seeing lower vaccine uptake. And then strike teams, which is, again, bringing vaccine into a setting. And then here's what we're doing with provider enrollment. So much of the work, especially over these last couple weeks and ongoing, is building these vaccinating partners. We obviously started with our 35 acute and specialty care hospitals We have more than 250 now long-term care facilities that are enrolled and scheduled for visits from pharmacy strike teams, working with Walgreens, CVS, and PharmScript. That's skilled nursing, assisted living, behavioral health. We're working now on some of the planning where there are other congregate facilities that are not part of that program. We also are now up to more than 250 vaccinating provider sites enrolled. This is really good, really important. There's more, dozens more being added every day, and this is one of the things we're going to want your help with, which I'll explain. This is our outpatient clinics. The idea is if an outpatient clinic is regularly a clinic that vaccinates Chicagoans, we want to get them enrolled, we want to get them vaccines. We've got more than 100 outpatient clinics already enrolled. We've also got about 100 federally qualified health centers already enrolled, urgent care providers, and then our pharmacies. So in addition to Walgreens, CVS, PharmScript, this week we've been getting Jewel Osco, Walmart, Mariano's, Independence. Getting these people enrolled means we can push them vaccine, and especially in parts of the city where we're seeing lower uptake, we want to get these providers enrolled and then help people get connected to vaccine there. Our mass vaccinating sites and pods are expanding very quickly. We expect to be up to almost 5,000 appointments there by next week and going from there. And right now, these vaccinating partners are first vaccinating their own staff, secondly, our other unaffiliated healthcare workers, and then looking ahead, like I said, probably beginning next week with unused doses to some older Chicagoans. And we're putting together language right now. Again, I want to see some vaccine allocated, but that's the idea. This is just the last thing I wanted to share, and we'll send this around. If you're hearing from doctors or nurses or retired folks who want to help, this is how they register. IllinoisHelps.net. They select Chicago Medical Reserve Corps. This is not new for COVID, but this is how people sign up. And then basically you can see, what do MRC volunteers do? Number one is administering vaccines. So this is where we would ask people to go. Chi.gov/COVIDvax is our website. I'm not going to take the time right now to pull it up and walk you through it, but I know your staff. We've been pointing people there. We have information in many, many languages now available. We have frequently asked questions that we're updating daily. We've been making a lot of videos, English and Spanish especially. We'll expand that as we have capacity. And we will be getting federal funding. We've not yet received the federal funding to support vaccine distribution at all. Like just a very little bit, but that large package that was passed at the end of December, that's not arrived yet, but we will be, that when we get that, that's when we'll be able to really much more dramatically expand our ability, particularly for some of the strike teams in the pods. So that is what I had to share. Let me go back to this list and see, just so at the highest level, we did an overview. I'm sure you'll have questions. When will seniors or individuals living in senior buildings be eligible for vaccine? That eligible part will likely begin as soon as next week, with the priority, though, still going to unvaccinated 1A, and then the availability will expand from there. We are following state guidance. We will be prioritizing essential workers in 1B in terms of getting the different streams going. For example, within grocery stores, we'll be thinking about getting vaccine to large grocery stores, but also small grocery stores. Smaller grocery stores would come to our pods, larger grocery stores would get straight teams. How can a Chicago resident not affiliated with a healthcare system receive vaccine? So I think we've done a pretty good job of getting this out, because we've had more than 5,000 outpatient providers sign up. This is the chicagohon.org/COVIDvax is where all healthcare providers go for all questions, and we link to it all over the website, anywhere where it says healthcare providers. We have been, and to the second point, outpatient workers have requested an appointment, haven't heard back what to tell them. This has been getting those outpatient providers assigned to vaccinating partners and getting appointments. Again, we had started at 115,000 of them. We were still down to about 66,000 outpatient healthcare workers that needed vaccines. So they're all getting set up with outpatient providers, healthcare workers, our pods. Again, we're not waiting to move, but they do need to get appointments. long-term care facilities are being scheduled. If someone has a specific question, but every week there's more. I think there's 47 that are starting this week, and each week up to that more than 250 that are enrolled over the next really few months. They will be receiving vaccine, multiple visits for vaccine. And then does the future vaccination plan include locations? Yes, pharmacies, doctors' offices, but also community-based centers, but in partnership with our outpatient providers for City of Chicago. Outpatient clinic becomes a vaccine provider, again, chicagohun.org/COVIDvax. And if you have outpatient providers in your area that normally give vaccines, we most want them signing up to be a vaccine provider. We've been doing a lot of messaging around this, but one way that you can help is letting your outpatient providers know. There's some paperwork they have to do. They have to fill out some paperwork on the federal side. They have to sign up for eye care on the state side. We've got help for them to do that, but getting that paperwork done means sooner they are able to get vaccine. And our plan is to keep sending vaccine to really all the providers, as much vaccine as we get. An organization can become a vaccine provider. You obviously have to have someone licensed to give vaccine. We would point you back to that same website, and there are more specifics around that. Some people have been asking about locations of being a vaccine provider. If there are large sites in your wards that you think would potentially be good for a pod down the line, we are interested in hearing about them. We know about all the park sites, we know about all the school sites, but if there are, even large, churches, auditoriums, they have to be big because there has to be social distancing, and we have to monitor everybody for at least 15 minutes after we give vaccine, and that creates actually a lot of space considerations. So if you are identifying spaces that you think could be useful, we're interested in hearing about those. Again, that's not for next week, but planning kind of down the line, especially in some of our communities where we're seeing lower uptake. And then I provided the information about volunteering to assist, and then individual people to sign up. There is not a process at this point for individual people to sign up for vaccine because we are not yet sort of open for 65 plus. Where people are wanting to sign up, we are sending them to Chi COVID Coach, the same thing that we've been sending them to all along. We are texting out updates and information for people who are enrolled. So if you've got people who are just feeling anxious, they can go there and enroll. But we will be, and we'll be transferring information from Chi COVID Coach over to opportunities for signing up as that is more available and there's some more tech. But nobody is delayed at this point, except for outpatient providers in terms of signing up for vaccine. And again, first and foremost, we'll want people to get vaccine through their own healthcare provider. So with that, I am happy to take, I'm sure, your many questions, and thanks again for all the work that you're doing.
Thank you, Doctor. I'm going to start with questions. I'm going to intersperse some of the non-committee members with committee members, but I will start first with committee member Alderman Smith.
Oh, thank you very much. I really appreciate it, Chairman. Dr. Arwady, so an independent pharmacy can become a vaccine provider by just going on that website, is what you're telling us.
That's correct.
And signing. Okay, that's easy. I've been getting complaints from people who are in other states claiming that Florida, in particular, is getting more vaccine. And I went on the website, and it looks like they are receiving more vaccine for 100,000, or distributing more vaccine for 100,000 than we are. Now I saw, and so I wanted to get your understanding of, and I understood from reading some articles that it appeared to be that the CDC was doing something slightly different in how they were counting how many vaccines to distribute. Nonetheless, and that there's also, frankly, a lot of chaos in Florida about people standing in line to register for a vaccine, which seems really dangerous to me. So could you comment on this? Because, it's getting to this moment where people are saying, how come they're going first?
Yeah, absolutely.
And I really want you to address that very strongly.
For sure. So thank you for that. And a couple of things. So first, vaccine has broadly been allocated by population. However, one thing I want to sort of put on that is that there was no consideration for where there might be more healthcare workers. So the city of Chicago, for example, is a major healthcare center, right, for the region. We have significantly overrepresented in terms of our number of healthcare workers, not just who live in the city of Chicago, but who work in the city of Chicago. And this is again, about 40% of our vaccine for non-Chicago residents. We did not get additional vaccine, and neither did some of the other cities that are big healthcare providers. And that means we just have more of these folks to get through. So that's sort of one piece. I think in terms of sort of the Florida approach of kind of come one, come all, there are concerns about, as you say, safety related to that, but also we are wanting to very much think about equity here as well and make sure that vaccine is being distributed geographically across the city and being made available in a way that does not put perhaps the people most motivated to get up and wait in the line for 48 hours. If we have a plan that lets the people who are the loudest get the vaccine at all points, we will not end up with a city that has appropriate vaccine uptake that would get us past COVID in the same way. And so we are here working, first of all, to make sure that as soon as vaccine arrives, we are pushing it out to providers. We are working to, as I noted, really from next week, allow any unused vaccine, as we continue going through 1A, go ahead, start with your 65 plus. Nobody wants vaccine sitting on the shelf. But this is going to be appointment-based still, at least right now, different from Florida. And so whether that's appointments in the pods, whether that's appointments for our essential workers, whether that's appointments with your clinical provider, these are going to right now be appointment-based. And I think more as we move more into 1C is where we would probably start doing more of the community-based, sign up. But the goal here is to make sure that we can make vaccine available, and that we don't have 360,000 Chicagoans who are over the age of 65, thinking that they can show up at a mass vaccination site and get vaccine because we just don't have the vaccine. So I hope that helps address some of it. One other thing I'll just note is there has been a lot of problems with the data. I just want to be honest about that. It's a little bit of a fragmented system in terms of the federal data, the state data, how it's all flowing. City of Chicago is using the state's immunization registry, iCare. We felt that was important, again, given how much movement we have across the city. But I can tell you that these are systems that are being stretched, just as we have seen in other spaces. And there's been a lot of work across the country to work on it. But there are entire hospitals in the city of Chicago that have been vaccinating very beautifully. Their data is still not coming through. So we're not seeing their vaccination numbers just yet. And every week that's getting better, and there's a big team that's working on it. But it has to do, it's not that the vaccine is it's not that the data is it's being reported, but if the computers aren't talking to each other behind the scenes, we're having to do a lot of cleanup there. So part of this increase that you're seeing is actually just across the country, some of that data and just computer work getting fixed. It's also why we've had some delay on being able to share race ethnicity data, where we looked at that iCare data from the state. 40% of the vaccine data was missing race, and 85% was missing ethnicity. When we looked into why that was, a lot of it has again to do with how the electronic health records are and are not connected to the state registry system. So there is additional race ethnicity data, but it is not flowing at this point. So our team here, we feel really strongly about sharing this, is working on what's called imputation, where if you have unreported race ethnicity data, you can use other sources to estimate this. And we do expect to be able to share this just in the next few days. But I do want you to know we're making data available publicly as soon as we have it and with as much transparency really as we're able to. But there is some behind the scenes work that has to do with ongoing techniques.
And my last question is, how quick would you say your turnaround time is from when you receive a vaccine to when you have to do this distribution step, which is a very wise way of doing it. How quickly do you think that's happening? And I'm sure you're very focused on that.
Yes, we are. And I have a team that is a large team that does nothing but think about all these logistics and work on the cold chain and the monitoring and, and making sure the second doses are going to the right place with the right vaccine. It is a very large lift. The way it's working right now, we only have like less than a week's notice about how much vaccine we're getting the following week. We don't know how much is coming sort of after that. And that's where I think some of the largest sort of hue and cry has come. And that's where I am hoping at the federal level, they will just release it more. We have built the capacity here in Chicago. I can hold 130,000 doses if I needed to of the Pfizer vaccine, right? If they were going to send it. But we have a lot of capacity to be able to ship it out and develop it. So every week we look and see how much vaccine is coming in. And our goal is to get at least 95% of that vaccine out every single week. Like not sit on it, push it out. Broadly, that's been going very well. It's a little bit of a mix. You want to make sure you've got enough outpatient providers so that you're sending enough that you can use it. But really, this week we've gotten a lot of those enrolled. And if the federal government says you get 100,000 doses next week, love it. Like I can do that. I can send that. We've got the plans to be able to go to all 250 of our outpatient providers that are enrolled while we stand up pods. So that piece I don't have significant concern about. I think it's more. There are messaging things here, and there are just on the distribution side. I need all of our partners to keep going with their healthcare workers. We didn't see the uptake we were hoping to see, especially in hospitals. We know a lot of people who are waiting to see. We just started in the last week second doses. We heard from people. We've been doing surveying and focus groups. A lot of people were saying, I'm not saying I don't want it, but I want to see my coworkers get that second dose and do well. So we are also saying to all of our hospitals, please go back again, work on your healthcare hospital workers who maybe didn't step up right at the beginning. So it is a little bit, there's just multiple lanes going here. We want to push vaccine out as fast as we can and then give the guidance that makes sure all of that vaccine can be used and open that up. And if we hear at the federal level more is coming, we'll be able to open up more quickly.
All right, thank you very much. Thank you, Mr. Chairman.
Thank you, Alderman. Our next speaker is Alderman O'Shea.
Thank you, Chairman. Thank you for all your efforts, Commissioner. I really appreciate your strong leadership during this pandemic. Allison, it's my understanding that the first and second vaccine doses are different. Is that in fact correct?
No, the first and second doses are the same. That's true for both Pfizer and Moderna. They're the same dose. They're the same. There's nothing different about them. But the thing that's important, and we've been pushing this hard in the messaging, and again, I decided not to sort of do vaccine education, but happy to answer any questions, obviously, about that. In the trials, the Pfizer and the Moderna vaccine both showed only about 50, like Pfizer was 53% protective, Moderna was like 45% protective, only about half protective after the first dose, and that 94-95% protection comes in after the second dose. The first dose starts teaching your immune system, and then that second really serves as kind of a booster, and then your immune system, based on what we measure, is able to provide that high level of protection. And so they are the same, and this is where some of this conversation about might we space out a little further? I don't know if that's where you were going, but we're getting questions about that. It's been a national conversation. Might you not wait? Might you not sort of quote hold back the second dose to make sure that more people can get first dose? That's what the UK is doing. That has not yet been guidance from the FDA or the CDC, because all of the trials were done, in a particular way, and we want to make sure that there is that protection. So it's one of the most discussed conversations happening nationally right now. We are very much dedicated still to making sure that if somebody in the city of Chicago gets a first dose, they can get that second dose at the same location, the same thing, that they get sort of that full protection, because our messaging has been around protection, based on that trial. We are hearing that the incoming Biden administration is likely to release their vaccine plan potentially tomorrow. As this becomes more clear, we will shift guidance if needed, but I feel very strongly about making sure that the promises we're making to Chicagoans about the protection of this vaccine, that we're following these trials, that we continue to follow where that science has been done and not sort of overpromise.
And when we talk about, we're trying to get our public school students back in the classrooms, where are we at with possibility of providing the vaccine to teachers and faculty through CPS?
Sure. So first, we are already working on getting the healthcare workers within CPS and all of our other schools. Remember, these all come together. So daycare and K through 12 have been, CPS has not been in person, but many of these others have been in person throughout this whole time. They're all in this group. Planning happens sort of for all of them together. So we've been working to make sure that the CPS nurses are getting scheduled for vaccine themselves. And we will be making in phase 1B. Obviously, they're included in that essential worker group. These next essential workers, I anticipate being able to start somewhere in the kind of February to March range. Obviously, there's a lot of interest in education, so we're hoping some of that will start perhaps more on the February side. I don't want to, again, we get a lot of vaccine, this will be able to speed up. There's about 150,000 Chicagoans who are in that education group here in Chicago. Again, I got 360,000 people over 65. I've got hundreds of thousands of essential workers, 150,000 of which are in education. So we're working right now with CPS around planning here. We would be distributing vaccine basically to CPS not all at once, on a week-by-week basis, just as we are doing to our hospitals, as we've done everywhere else. And then through their own school-based health centers, through their nurses in partnership, would make vaccine available to all teachers and staff in those schools. I think that's going to be a process sort of over, hopefully we can kick that off in February, kind of February, March, then a second dose of vaccine, of course it's Moderna, likely. So that would come, in sort of April, May. Protection is considered broadly, a week or two after that second dose. So this is going to be rolling out very much over this semester, and I would anticipate, I hope we'll see good uptake in those settings. So we will likely, to kind of help you understand, like daycares are examples of unaffiliated providers in most cases. They tend to be very small. Many of them may have fewer than 10 employees. We would be sending daycare workers more to our pods or to have them come to places where we are providing vaccine. Whereas for school systems, private, parochial, public, we would send vaccine to them and make sure they have a vaccinating provider so that they can get educated at their place of employment. Also true for grocery stores, also true for public transit, etc.
Okay. And what more can we do as individual aldermen in our communities to help with the effort? Obviously, I'm in constant communication with Alfonso, but what more can we do in our neighborhoods?
Yep. So right now, certainly, if you are aware of outpatient providers, especially the ones that may be a little more under the radar. We know the FQHCs very well. We know the large ones that are connected to, large healthcare systems. But there are a lot of, smaller providers, independent pharmacies. We have been doing outreach. I sent a letter through the regulatory system to every licensed physician, dentist, etc. in the city of Chicago to try to pull them in on this. But getting those providers enrolled and getting their work done is important, especially in parts of the city where we are going to have some more challenges here. So your outreach there is very helpful. The work about thinking ahead towards pods. I would also, there is a lot of conversation, as you know, happening around timing of vaccination for government leaders, right? Which, we've seen at the national level, some of the lawmakers be vaccinated, and I think this is an active conversation here. So I would, just at a very personal level, like ask each of you to think about, are you ready to be vaccinated? If you feel like you are not ready to be vaccinated, we would actually like to hear from you and help, see if there's additional, like for you personally, we think you are going to be important public figures as we move ahead here. I can't exactly provide timing of this. There's a lot of conversation, but we are interested in really highlighting you all, as you are yourselves able to be vaccinated, as you've seen us do for for healthcare workers, as we move ahead a little bit further here. And then just education. Down the line, not that too much further down the line, but once we have some more money, we are anticipating doing things like funding community-based organizations in your wards, to host vaccine conversations, education sessions, to link them up with healthcare workers who've been vaccinated who live in your wards, kind of this healthcare champion idea, doing some stipends there. Again, trying to really get this conversation going. We're talking to philanthropic partners about moving the on-the-table conversation to be about vaccine. We've hired a number of Chicago-based communication firms to help partner in terms of getting this out. There's focus on healthcare workers, there's focus on Black Chicagoans, Latinx Chicagoans, all Chicagoans, essential workers, and there will be a lot of material to push out. But then also, once we're, again, a little further down the line, we anticipate opportunities for example, particularly in the parts of the city where we are seeing lower uptake, some incentivizing for community-based organizations to be, helping, for example, identify 100 people who live in the ward or in the zip code who want to pre-register for vaccine, and the city being able to, and the space, and the city would provide the vaccine for the big thing. This is not now, I want to be clear, this is sort of down the line, really in 1C. But I think the more you can have right now, sort of vaccine conversations, highlighting people on your own social media, you've got a lot of healthcare workers in every ward that have been vaccinated, and we've been identifying champions who want to speak up, who want to be part of this. I am more concerned about driving demand. I know this sounds kind of weird because there's a lot of people who are like, I want vaccine right now, but in the long-term way, I am more concerned about driving demand, particularly across Chicago, than I am about our ability to handle the logistics and supply. We can push vaccine out just as quickly as we get it, but where we're seeing vaccine hesitancy, that's going to take a lot of work to overcome, and that's where this Protect Chicago work will play in. So we're interested in your ideas about that too. A number of you are hosting town halls. I've seen PSAs that some of you have done. We want to support you in that. We've been building up sort of a little bit of a kind of a speakers bureau at CDPH, people who can come and join and help make sure that we're getting that education out, and just having it be sort of a conversation. So those are some of the things, in addition to some of the websites and the more specific materials that we have here.
Thank you, Doctor. Thank you, Chairman.
Thank you, Alderman. Alderman Cardona.
Thank you, Chairman, and thank you, Dr. Arwady, for doing this and being out there a leader in the communities under this pandemic. I have two questions. One is, how would you know what seniors did get vaccinated and those that didn't?
Yeah, good question. So, our epidemiologists, first of all, at the city level, have done, we've been doing a lot of mapping related to all of these essential workers, as well as where do our 65, 75, et cetera, live from a planning perspective. And so at an individual level, the way this works is that when somebody gets vaccinated, the whole country gets the same card. There's my vaccination card. I've had one dose. When I get my second dose, it gets in here. The whole country uses the same physical card. But then this information, we are not requiring identification. I want people to hear that loud for the undocumented part. But you do need to provide your name, your address, your date of birth, because this goes into the state immunization registry. This registry is only available for public health professionals. It's not used for other purposes. And it's the same registry that we use to keep track of flu vaccine and childhood vaccines, et cetera. And so that is how we know at an individual level that somebody has been vaccinated. It's how we then communicate to people when they need to get their second dose. It's how we, when they come back, that it is the right, that, we're not giving somebody Pfizer and then Moderna. They got to get the same second dose. There's a lot of logistics related to that, and we do need to know who individuals are. So we will be tracking, and if you've explored the website, you've seen at the high level, we've been doing maps of, what does uptake look like sort of across Chicago. we'll be doing some of that in a more focused way too. 65 plus, what percentage are getting through in the different zip codes, and then we'll be pushing additional resources to help support in areas where we see lower uptake. So this is where I don't think realistically we'll have the ability to send a strike team to every independent living, senior living in the city, but in zip codes where we're seeing lagging vaccine uptake, that's where we're more likely to prioritize just sending additional resources there. It doesn't mean that the people over 65 in the other areas can't get vaccine. They can get it through their provider, they can get it through things, but in terms of bringing vaccine and lowering those barriers, will be focused in particular areas. And then we've also been working on things like making sure, free Uber and Lyft rides. Like there's a lot of other kind of things that go in there. But at the most basic level, we do keep track across the whole country at an individual level, and that is going to be important down the line too. I think eventually you're probably going to need to show proof of vaccination to fly internationally, right? Not now. Like these kinds of things are going to be in there, and it's important that people are going to be able to show that in an official way much clearer.
Okay, thank you for that. Another question is that you have the vaccine under 1B. Does the example of the laborers, streets and stands, do they fall under that?
So the way
Under 1D or they're
so the way we're thinking really about 1B, those groups that I highlighted were designated federally, but they match very well where we have seen major outbreaks and where we have disproportionately seen, a lot of our hardest hit community areas have a lot of essential workers in exactly these categories. And so we, particularly from an equity standpoint, we very much like the concept of open to all older Chicagoans, but then do some sort of jump start in these food processing plants, right? Like they need vaccine, right? In the same way where we've seen the outbreaks protection, but it also helps get additional vaccine and lower barriers in some of the hardest hit communities. So if they are not specifically called out on that list, they're not in 1B, but they're in 1C. So for city workers, that means that the public safety people are, and where we've seen again a lot of cases, a lot of hit very hard, are in that 1B. The public transit, CTA are there. The rest are not necessarily in, particularly across Chicago, than I am about our ability to handle the logistics and supply. We can push vaccine out just as quickly as we get it, but where we're seeing vaccine hesitancy, that's going to take a lot of work to overcome, and that's where this Protect Chicago work will play in. So we're interested in your ideas about that too. A number of you are hosting town halls. I've seen PSAs that some of you have done. We want to support you in that. We've been building up sort of a little bit of a kind of a speakers bureau at CDPH, people who can come and join and help make sure that we're getting that education out, and just having it be sort of a conversation. So those are some of the things, in addition to some of the websites and the more specific materials that we sent you.
Thank you, Doctor. Thank you, Chairman.
Thank you, Alderman. Alderman Cardona.
Thank you, Chairman, and thank you, Dr. Arwadi, for doing this and being out there leader in the communities under this pandemic. I have two questions. One is, how would you know what seniors did get vaccinated and those that didn't?
Yeah, good question. So, our epidemiologists, first of all, at the city level, have done, we've been doing a lot of mapping related to all of these essential workers, as well as where do our 65, 75, et cetera, live from a planning perspective. And so, at an individual level, the way this works is that when somebody gets vaccinated, the whole country gets the same card. There's my vaccination card. I've had one dose. When I get my second dose, it gets in here. The whole country uses the same physical card. But then this information, we are not requiring identification. I want people to hear that loud for the undocumented part. But you do need to provide your name, your address, your date of birth, because this goes into the state immunization registry. This registry is only available for public health professionals. It's not used for other purposes. And it's the same registry that we use to keep track of flu vaccine and childhood vaccines, etc. And so that is how we know at an individual level that somebody has been vaccinated. It's how we then communicate to people when they need to get their second dose. It's how we, when they come back, that it is the right, that, we're not giving somebody Pfizer and then Moderna. They get a clean second dose. There's a lot of logistics related to that, and we do need to know who individuals are. So we will be tracking, and if you've explored the website, you've seen at the high level we've been doing maps of, what does uptake look like sort of across Chicago. We'll be doing some of that in a more focused way too. 65 plus, what percentage are getting through in the different zip codes, and then we'll be pushing additional resources to help support in areas where we see lower uptake. So this is where I don't think realistically we'll have the ability to send a strike team to every independent living, senior living in the city, but in zip codes where we're seeing lagging vaccine uptake, that's where we're more likely to prioritize just sending additional resources there. It doesn't mean that people over 65 in the other areas can't get vaccine. They can get it through the provider, they get it through things, but in terms of bringing vaccine and lowering those barriers, we'll be focused in particular areas. And then we've also been working on things like making sure, free Uber and Lyft rides. Like there's a lot of other kind of pieces that go in there. But at the most basic level, we do keep track across the whole country at an individual level, and that is going to be important down the line too. I think eventually you're probably going to need to show proof of vaccination to fly internationally, right? Not now. Like these kinds of things are going to be in there, and it's important that people are going to be able to, show that in an official way much further down the line.
Okay, thank you for that. Another question is that, you have the vaccine under 1B. Does the example of the laborers, streets and stands, do they fall under that?
So the way
Under
we're
1B or during?
Yeah, so the way we're thinking really about 1B, those groups that I highlighted were designated federally, but they match very well where we have seen major outbreaks and where we have disproportionately seen, a lot of our hardest hit community areas have a lot of essential workers in exactly these categories. And so we, particularly from an equity standpoint, we very much like the concept of open to all older Chicagoans, but then do some sort of jump start in these food processing plants, right? Like they need vaccine, right? In the same way where we've seen the outbreaks protection, but it also helps get additional vaccine and lower barriers in some of the hardest hit communities. So if they are not specifically called out on that list, they're not in 1B, but they're in 1C. So for city workers, that means that the public safety people are, and where we've seen again a lot of cases, a lot of hit very hard, are in that 1B. The public transit, CTA are there. The rest are not necessarily in 1B, but I want you to understand that as we set up these structures, the idea is they just keep continuing. So like we've got a public safety pod going. We'll be getting a sort of city, right, for city public transit workers going. There will be other opportunities for sort of city workers that we will use to make it, again, easy for city workers to be able to get vaccine where they work. But most of that is going to be in 1C. But 1B is really just the jump start. It's like get it into the places we most need it to help get COVID under control. And then 1C is really when it opens up very widely.
Well, thank you for that. But I got to ask you, for the Chicago Public Libraries, the staff and all that, they're essential workers. I think they should be in 1D because they work with, again, with teachers, Chicago Public Schools, and so forth. I feel like we should consider them being in the category if possible because they've been essential workers and they've been COVID. We have people going through the library, so I think they should be in 1B category with the teachers and so forth.
Yeah, thanks for that. What I can tell you is that we've seen fewer COVID infections in Chicago Public Library staff than we've even seen in Chicago Department of Public Health staff, honestly, that have been worker-based. And we very much appreciate that they have been open and they're essential and they'll be in there. But where, education settings where we've disproportionately seen cases and outbreaks and the risk has been highest. And so, I want to get the Chicago Public Library folks vaccinated. We will be getting a plan for them that will make it easy for them to get it, but it will be just a little bit later. It's more likely to be, in that kind of March, April time frame, whereas the others may be more in the, February, March time frame. And we get a lot of these requests, and, I wish that we could say yes to all of them, but we don't have enough vaccine even for the people who are in there right now. But my goal is to be communicative to all of these workers, et cetera, about the more that we can give them a sense of what this will look like, that yes, we are planning for them, and that if we're not talking June, we're just talking, a little bit later down the line. And certainly our City of Chicago workers, not just the librarians who've been coming to work every day, we want to, again, make sure that they have good access to vaccine, but it's just balancing it against space emergency.
Thank you, Dr. Arwady. I'm done with my questions. Thank you.
Thank you. Our next speaker is Alderman Garza, and it's going to be followed by Alderman Hopkins and Dow.
Thank you, Chairman, and thank you so much, Dr. Arwady. Your leadership is stellar, and I never cease to amaze me what you're doing during this time. So you're appreciated. Your staff is great. I could be here for 3 days singing your accolades, and I want to be respectful, but I just want to let you know that I am so glad that you're driving this ship. I really mean that. Do you think that we could get a list of where the doses have gone? We don't need it broken down by ward. If you can just, it's easy for your staff to say where they're gone. And I don't know if this is a misconception, but I'm hearing that there are some hospitals that have received doses but can't find people to take them, and they're sitting on these vials. Is that correct or no?
Yeah, so let me speak to kind of both of those. And first, thanks for the comment. I'm just the face here. My team, everybody at CDPH is doing three people's jobs right now, particularly with this vaccine, how it works. So thank you for that. So in terms of sort of both data and then hospitals, let me take the last part of your question first. So we, as you know, worked really hard to make sure that all 35 hospitals in Chicago would get vaccine that very first week, and we have continued providing vaccine to every hospital in Chicago as they have requested. What we have seen is that there has been a inconsistent uptake of vaccine in some of these settings, and this is where some of this is around. We don't consider a hospital done if fewer than half of their healthcare workers have gotten vaccine, and so we've been encouraging them to continue if there are people, especially now that they're into second dose. What we did is we basically said, you start in the hospitals, please start with your most at-risk healthcare workers. Right? The ones who are working in the ICU and the COVID wards and the emergency department, then expand out to all of your other hospital-based employees. We want to make really sure that the security officers, the cafeteria workers, everybody who is in these settings is getting vaccine. And then we expanded to, and really this has just been over the last week or week and a half, as they started saying, you know what, we're not getting as much uptake as we had thought. We have been matching these hospitals with outpatient healthcare providers. So I have 800 dental offices in the city of Chicago with all of their staff. They're not going to be vaccinated, they need to be vaccinated. So we've been sending hospitals lists of here are outpatient providers that are in your zip code, in your area, and we've been matching them up. So it's been like, dental over here, morticians over here, outpatient, over here, home health over here, physical therapists over here. And that's where there's this, I think, slight kind of misperception sometimes that they're saying we can't use any more doses in terms of hospital workers. We've said, here's a lot of outpatient healthcare workers to work on. If there are if you work with a dialysis center, if you work with any of those, use your vaccine there. And then beginning next week, this is where we're going to say, if you still, keep going in 1A, but if you have vaccine that you are otherwise not using, you can start using it in older Chicagoans, but prioritize in your existing patients among those who are at highest risk. So in terms of how many doses have gone where, this is a little bit complicated again because of some of the data I share. So what we are able to report on well, and what we are reporting on well, is where Chicago residents live who get vaccinated. And we are providing, to the hospitals as much vaccine as they have wanted. We have given them every single week as we've had vaccine available. But there are hospitals that only have, 200, 300 staff at them. They would have only received, in some cases, maybe 200 vaccines. If two-thirds of their hospitals have said yes. And then there are healthcare systems that have gotten, tens of thousands of doses of vaccine who employ people from all over the city. So we are working. We actually have the Inspector General team has a lot of, we've been pulling people from all over the city. They do a lot of dashboard type work for us, and we're having them work on more of this kind of internal dashboard distribution, where it's going, what does this look like. And we will share more of that with you as it is available. We can share at a high level, the number that have gone to hospitals, the number that have gone to long-term care, etc. But the way that we'll report most of this out is not so much where it'll be the uptake of where people are actually living, because that is how the data is actually reported up, if that makes sense.
Yeah, it does. Unfortunately, I don't have a hospital in my ward at all. So, and I border Indiana. I mean, I could walk to Indiana from my house, so, which is a bad thing because they're wide open and we're not. So, I think it would just help us if we could, know, because you brought up a category that I don't think, morticians and dentists. Like, I've heard from them, like, hey, where am I at? How am I going to get it? So we're just going to, basically, you want us to just steer people to this COVID, the COVID vax, the dashboard.
That's right. And they've all gotten the information, and we've heard, literally, I don't think there's too many dental offices. Like, I really think we have heard from the huge majority of them at this point.
Right.
But what we'll be able to do, and we will be providing and mapping all of this, is all of our registered vaccinate forms. So there's more than 250 of them at this point. And so even if you don't have a hospital in your ward, you have a clinic, you have, and these will be vaccinated.
Can we get a list of the registered vaccinators, or is that on the dashboard?
It is not on the dashboard, and we can, this is one I've really been pushing the team about, but literally, we're adding like 100 a week, right? So it's going very fast in terms of the increase. But yes, I think that's a good idea in terms of a visualization.
Yeah, we can help push people to those sites.
Yeah. It's just that it's going to be rapidly evolving, right? Because more and more are going to come online. We've been prioritizing any federally qualified health centers. Like I said, more than 100 of those sites are already enrolled, and we want them all enrolled. And then adding anybody. We've started with anybody who is diagnosing COVID, basically seeing COVID patients, doing a lot of that's sort of how we've been going in order. But at this point, we just want as many people as possible enrolled to be vaccinators, because it means we can send them vaccines.
Okay, I will push people to that site to enroll to be vaccinators, and also to find out about this.
And it's just one per practice needs to sign. We don't need every individual person.
Okay, great. Thank you again. That's all the questions I have. And if you need me to sign up for a vaccine for PR or something, I'm in. I'm sure
there will be a little more coming about that, but do start thinking, just you guys yourself, I think it would be a pretty powerful statement to think about, sort of probably doing a lot of aldermen, about the same time. We'll think about that, and if you have thoughts about that.
Okay, thank you, Dr. Arwady. Thank you, Chairman.
Thank you. Alderman Hopkins and Alderman Dow.
Yeah, thank you, Mr. Chairman, and thank you to my colleague from the 10th Ward, Alderwoman Garza, for bringing up Indiana and the proximity to Indiana, because the B117 variant has now been confirmed as present in Indiana. It's been sequenced. It's been confirmed that it's there, and that's a real cause for concern. It's as Alderwoman Garza knows, there's no wall between Gary and Chicago. So if it's there, it's just a matter of time before it's here.
Not even Gary. It's right across the border here.
So that is something that is troubling right now, given this discussion about the vaccine and a little bit slower uptake than all of us would like. But I have a three-part question for Dr. Arwady. First of all, we're exclusively now in an appointment-based system for obvious reasons. It's necessary to control, access to the limited doses that we have. But is there any plan at any point to incorporate a walk-in system in addition to the appointment system? And if so, what phase is that likely to occur? And then the second part of this question is, have we done any modeling in terms of the time interval, the average time that's required to vaccinate a patient once they present? And to be clear, I'm not talking about time in line. So whether you wait for your turn for an hour or 5 minutes, the clock starts when you first have contact with that staff person, and then you fill out the forms, get a vital check if that's happening. I'm not sure that is. And then get vaccinated, and then wait for the 15-minute observation time. Do we have any idea on an average basis how long that's taking per vaccination?
Okay, sure. All right, so very just quickly on the variant, maybe just high level. Not detected at this point in Chicago, but as you know, we have no reason to think that it won't be, and potentially soon. The vaccine does work against this variant, which is good news, and it doesn't make people sicker, but it has the potential to be more infectious, more easily spread. This needs doubling down on the things that we know work. It also, though, if this really becomes a more predominant strain across the U.S., which it may, we may need to get a higher percentage of Chicago vaccinated to get to that herd immunity. So it doesn't change anything that we do kind of immediately, but it has the potential to change it. So just high level. So in terms of, I'll take your last part first. Yes, there's been a lot of time studies on this actually. We started this all the way back with our flu vaccine clinics. We tried drive-through and pods and a lot of different ways of giving vaccine with exactly these planning assumptions sort of in mind. The thing that is slowing us down the most, honestly, is that wait period. The fact that right now we are having to monitor every individual for at least 15 minutes and 30 minutes if they say yes to some allergy questions. And so where we think about throughput, and it's different actually in different settings. Our pharmacies don't have a lot of space in their pharmacy stores to monitor people for 15 or 30 minutes, right? I mean, they can tell them to sort of stay in the store and shop, but nevertheless, they are really limited to just a few people an hour. Large spaces, and this is what we're at the city colleges now, but we may even go larger depending kind of how this looks, is as much about the ability to get that monitoring in as needed. And as the weather warms up, we'll be able to do that outside, which will help dramatically if you could move people out sort of into a tent-based setting to do that. We also are doing some planning, again, for down the line and when it's warmer, thinking about some of that drive-through, but you got to have the monitoring. So there's pieces there. The actual sort of interaction with the nurse and the vaccine, only about 5 minutes. There is, not counting the line part, there's another, it's taking kind of also in that sort of 5 to 6 minute, the registration, the questions, the counseling, and then it really is, it's the longest piece of this right now is this post-vaccine monitoring. It's also why we can't just sort of go knock on doors and give out vaccines based on current safety protocols. We have to make sure that any vaccinating site, has the right equipment, has the blood pressure, has the training, has the epinephrine in case somebody were to have an allergic reaction. Again, we're not seeing that at an unexpected rate, but you just want to make sure, obviously, that the safety is there. So there has been modeling. We've also, even in our own city of Chicago pods, we've been doing this now for a week and a half. We've done a number of things to be able to speed up that throughput in terms of how people are moving, and we'll continue to be able to do that. In terms of walk-in systems, so definitely not in 1B, and probably not at the very beginning of 1C either. But I think what's going to happen here is when we get to a point where supply is actually exceeding demand, then I would imagine, particularly in communities where we're really wanting to further sort of help catch up to the rest of the city, I would imagine that we would have some more walk-in type settings, but I don't think that would be more until kind of late spring, realistically. And again, we've been talking about the possibility again when it's warmer, you have just a lot more capacity to do this in a that you're not as limited by the space constraints. And again, that's one way we're different from Florida, right? Also, I can't have people waiting in line for hours on end in the middle of January in we have definitely thought about walk-ins down the line. We have done lots of time studies and working to speed that up, and thinking about creative ways around especially the post monitoring.
Does the guidance currently suggest a vitals check? Because that would add probably 5 minutes, right?
Yeah,
Is anyone doing that?
there's no vitals check required. There are a series of questions, and we have people actually in the registration process right now answer those questions at the time of registration. And some of the outreach work with our Protect Chicago, et cetera, as we're going to be out, is actually helping people pre-register. That's what they're going to be doing in the door-to-door, with the iPads kind of way. Let me get you signed up for an appointment. Let me help you fill this out. Let me get the information. And so when somebody comes, ideally they can just pull them up. Their information's there. But if people sometimes they don't fill it out or they have questions, you do need to reinforce some of the safety type questions, and then do it. But we've done a lot to try to speed up anything except the actual vaccine and monitoring, and that's where some of this registration, the pre-registration is available. So for healthcare workers right now, we say basically, okay, dental office X, you're good to go. You're going to be coming to Malcolm X Pod or Rush Hospital or this outpatient care center. Here's your code. They then go into the system. They use their code, and the individual workers sign up for a slot and put in their pre-information and pre-registration. That's kind of how it works and how it will work moving forward.
Well, thank you, Doctor. I'm reassured by your answers, and I'm glad to hear everyone's looking to add efficiency to the process. This is a race. This is a race against time. With the B117 variant, it has enhanced transmission capability. The faster we can get vaccines in arms, the better off we're going to be. And it is taking, as you said, 15, 20, sometimes 30 minutes with that observation period. My concern is that there'll actually be some spread that occurs when we put, 75 people, cram them into a Walgreens and make them wait 30 minutes. That's taking a risk. So I'm glad that this is being looked at and addressed before we get to that phase when there's massive amounts of people showing up at pharmacies, outpatient centers, et cetera.
That's right. We have to have the spacing. We have to, all of that, that's absolutely necessary. We do a symptom screen for any COVID and a quick screen, even if they signed up before, make sure they don't have a COVID test pending. I mean, there's some sort of basic safety stuff here that happens. But you're right, it's a race. And early on, it's why we do a lot of these more mass vaccinating, right? Like if I can get 1,000 people through a site in a day, and I've worked to make sure that people who most need that vaccine kind of have the appointments and can come, that helps me get a lot done sort of in a controlled way when demand is high. And then as demand starts to come down, we can sort of afford in a race kind of way to be hosting smaller, more localized pods, and then even further down the line, walk-in type scenarios. But we're going to be in this sort of register way for some time and encouraging. Because the other thing is if you can answer people's questions and you can sort of be like, can I register you for a vaccine? What questions do you have? And then, you're looking at the system. Where is there a vaccine? If you have a provider, let's get that done. But otherwise, is there a pharmacy? Is there a pod? Is there a thing? Let's get you registered, even if it's a few weeks from now. Get your thing. Send you text messages so you're getting those reminders, and kind of get you started.
Okay. Well, again, thank you. My office has been conducting parking lot COVID testing clinics since May, and we're ready to assist. Anytime, tap us on the shoulder. We'll do anything we can to help with this effort. Thank you, Doctor.
Thank you, Alderman Dow.
Thank you, Mr. Chairman. Hello, Dr. Arwadi.
Hello.
I too want to extend my appreciation to you for your leadership in this pandemic. So thank you. I have a few questions I'm going to start looking for vaccine providers within my ward. You talked about large spaces. I'm assuming that mega churches, for example, might be good locations that you're interested in.
Yep.
Do you have staff available to help them fill out that paperwork you talked about?
We do. And if they go to that website, they'll see, here's the directions. There's an email address that's sort of dedicated for providers only who are working on this. We also worked hard. The biggest delay we were seeing in this was actually getting the registration done at the state level for eye care for registration. So we worked all the way up to the governor's office to make sure they put a lot of additional staff on kind of the health side there to make sure that if people are having questions or needing help, we can help, the state can help. Everybody wants to get these vaccines. These vaccines. And we've been really staffing up our capacity to support these outpatient health workers in doing it. There's a lot of interest, which is great. They do have to have a freezer. There's some training. There's a number of pieces that come, but it is our biggest goal. Getting vaccine, especially to parts of the city where we're concerned about uptake, is getting these providers enrolled. And then if from a trust perspective, being able to ask your healthcare provider your questions about vaccine, the more we can send people through those typical channels, we think the better.
All right. I have a lot of seniors in my ward, and since the announcement of 1B, I've been getting a lot of emails and calls, and I just want to be clear. So I have seniors who live in congregate housing. I have seniors who live alone in apartments or single-family homes. I have seniors who are connected to primary doctors and seniors who are not. So I need to know what is the protocol for, I want to be clear on what I'm telling you people, what the protocol is. Some of them are not digitally challenged and don't have the ability to go to a website to register. Do they register with their doctor? I don't know what to tell them. So if you could help me with that.
I can, and there will be much more coming about this, like in a lot of detail. Again, as more providers and advocacies comes in. But here's where we are right now. Likely beginning next week, healthcare providers will have the opportunity, if they have unused vaccine that's not going to 1A, start reaching out to their highest risk patients, their existing patients, to be able to start vaccinating them. But there is not at this point a place or an ask for Chicagoans broadly to sign up for, sign up at this point. Odds are not yet going to be on 65 plus, etc. The number one place where people over 65 are going to be vaccinated is their healthcare provider if they have a healthcare provider. And that is going to be a top line message all the way down. And that's going to be as true in January as it is true in April. That the first place we want, especially those are Chicagoans who may have underlying conditions and depressions and all the rest of this, is the same place they would go to get a flu shot, etc. Pharmacies are going to play an important role where we have older Chicagoans who are not connected or as connected to primary care. And my epidemiologists have done a lot of work here in terms of, we've done some ranking by community area in terms of what percentage of people report that they have a primary care provider. We know which areas are pretty well connected and which areas are less well connected. And as we think about, again, how are we lowering barriers to vaccine, wanting to make sure that people who live in areas that may be less connected to primary care have more access to pharmacies in that area, and that's where some of the appointment pieces are going to be done. There will also be strike team work that will be happening after we're through the true congregate senior living. So if people are living in assisted living, they're already in, it's happening. It's really as we move to more of these independent living settings that are still senior-based, CHA, other independent type living situations, that we are going to be working, again, the city directly, in partnership with hospitals, outpatient providers, pharmacies, to do some pre-enrollment and then on-site closed for people who live in those settings.
And how close are you to rolling out this information?
None of that is going to happen until February at the very earliest.
Okay.
Yeah.
A question on how you differentiate people over 65 years of age who have underlying conditions versus just somebody who's 65 years old and they're.
So the tier is open to everybody over 65 years, right? What we are asking, though, our healthcare providers to do is just as we've done sort of in all of the tiers to date, try to prioritize, as they're able to, the patients that they think are at highest risk of severe COVID outcomes. And so we are asking providers, to be as much as possible, starting with those who are over, who are really the oldest and have the underlying condition. When we are opening more public points of dispensing, et cetera, that would be open to seniors, pharmacies, et cetera, it would just be 65 plus.
Okay. Can I get from you a list of the long-term care facilities that you have identified in my ward and the daycare centers that you have identified in my ward, and information on which of those have had access to vaccines that you, just so I can keep abreast of.
Sure. So what I think we'll do, because there's probably a lot of interest in that, I think what we'll do is think about how to make available sort of to everybody, some of these lists and these maps of long-term care facilities that are enrolled and have appointments scheduled, clinical outpatient sites that are enrolled and can accept vaccine and will be able to vaccinate. And then as we get these other groups done, I don't have a list of daycares for you yet at this point. Because we're not in that, we've not started designating yet where those daycare folks will go. There's an industry group. We've been working with, they're within that education sector, and there's been some outreach, there's been some, a number of things that are happening, but what I want to provide is and to the public too, not just to you, where are the sites that people are able to get vaccine? I think that's what the most significant interest is, and then we can provide kind of as we move through these phases, what are the plans and kind of who's enrolled. But it'll be similar. I mean, I think the daycares honestly are going to be challenging, just like these unaffiliated healthcare providers are. We know there are a lot of daycare workers who may not be as fully, we have the list of the licensed daycare providers, right? We'll do the outreach to them just like we did for the, anybody who's licensed, we'll do all of that. But we know that there are others who are working potentially in this space. As we make appointments available, we'll be doing that outreach and opening it. So we absolutely commit to giving you sort of all of these lists and making them available as soon as they mean something. In terms of we're able to say these people have been scheduled for vaccine, have vaccine available, or that they've been connected and had appointments made.
All right, and then lastly, are you giving consideration for giving written notices to, people can, mail political advertising, and we can do gas and electric bills and the water department bills. Are you able to put information in these mailers that I think people who don't have access to computers or are challenged to get this kind of information about what's coming?
Yeah, most definitely. And this is where, again, sort of behind the scenes a little bit. Again, we've hired a number of communication partners to really help with this. We did a request for proposals for a relatively small amount of money because we had not received very much to support vaccine distribution, with the expectation that as more funding kind of comes through, we'll be able to significantly scale that up. But we've been talking, I think the water bill, for example, that's a great idea. Like thinking about the places where people are already connecting. We've been talking to BFSS and others. How can we make sure that people are kind of getting information about vaccine in those settings, and this digital divide thing, right, remains significant. CPS has also expressed great willingness to use its extensive channels to get information out, particularly when we're at a stage where it's you can get vaccine, here's what you do, here's how you connect, and then that Protect Chicago outreach work, which again is going to be more of this kind of door-to-door, let me make sure you have the information, will be continuing. It will be continuing. We've done some prioritization in communities based on risk factors, who've been hit hard by COVID, and then that's where we're not seeing as much COVID uptake, and we'll push a lot of those very, kind of resource-intensive but important outreach activities recognizing that people will need support. We're thinking about lessons that we've learned both from Get Out the Vote and Census in this. And so, Census was also about trying to really get everybody, including people who may not be as connected to the internet, right? Like helping them sort of get that. So where we've learned lessons as a city from those efforts, trying to incorporate those into the COVID vaccine.
Well, I thank you for your time. I also want to thank Alfonso for his responsiveness. Mr. Chairman, thank you for your consideration.
Thank you. Alderman Osterman.
Thank you, Mr. Chairman. I'll be brief. Want to echo everyone's great thoughts about your leadership, Dr. Arwady. And want to follow up on Alderman Dow, just so I'm clear, because we have senior buildings that are very anxious, right? They have to go through their healthcare provider first. At some point, some of them may go to pharmacies, and then at some point down the road, you either may have strike teams in place, or we can connect them independently with healthcare providers with vaccines.
Yeah. And there is a whole, we've been working with the AARP and others, like there's a lot around seniors broadly. Honestly, we are moving a little faster than we thought we'd be able to because we're hearing we're going to be getting more vaccine. And so I do, there will be a lot more information that will be available to help particularly these 65-plus-year-olds who are going to be confused. And we're working not just here, but with all of the other Northern Illinois public health departments, right? Because I want to make sure, like, suburban Cook County and, like everybody is kind of on the same page here in terms of messaging and timing to help cut down on some of that confusion and also make sure that vaccine is sort of available in similar settings. And they're all working on getting their outpatient providers enrolled at the same time. I think it's important for people to understand they are not late. There is nothing a person who is over 65 in the city of Chicago needs to do right now to make sure that they are getting vaccine. There is nothing they need to do. There is nothing they need to sign up for. We are just moving that as their healthcare providers are getting vaccine, they'll be able to start pulling them in sort of for appointments, which will be appointment-based, and more, more of this will be available really just in the next few weeks to come. And I know everybody's going to need messaging on this, so
We would, I think all of us would welcome that clear kind of messaging, because we have either property owners that have 500 seniors that they're all kind of calling us and are very anxious. So I think if we can help with that, I think, so that was the only thing and then teachers, I think that's something that at some point, February, March, April, we're going to look to roll out.
Yeah, and absolutely, we, like I said, already working on the healthcare workers in those settings, nurses, et cetera, and they in turn will be able to help vaccinate the staff and making sure that the training is done and everything is done. The goal, always it's like to push vaccine to these vaccinating partners, make sure they have the training, make sure they have the support, and then keep feeding them vaccine as quickly as they can get through it, and that we have vaccine.
Got it. Thank you very much. Thank you, Mr. Chairman.
Thank you. Alderman Cito Lopez.
Thank you, Mr. Chairman. A few questions, and I'm sorry, I have to take a few calls. I'm sorry, but I'm redundant. Thank you, Commissioner, for being with us this morning. My question around is the new mutation with the virus. How does that affect what do we know? Because there's a lot of very little information. What do we know factually, and how does that affect the new vaccine?
Okay. I addressed this very briefly, but the good news is that every time a variant emerges, and this is not the first variant that we've seen emerge, every single time it gets tested against existing vaccines as well as the vaccines that are still in trials and not yet authorized for use. And the vaccines that are available work against this variant. And there's no sign that there's been a variant at this point that the vaccine would not work against. And in fact, the way the vaccines are being developed, like a single mutation would not be likely to make a vaccine not work because of the way they target sort of the spike on the coronavirus itself. So top line is that, vaccine is more important than ever, right? In terms of getting rollout and having people take it. We have no reason to think that the vaccine would not protect people against this variant. Also, there's no evidence that this variant makes people sicker, which is also really important. And one of the things that we're always sort of on the look, in terms of worry, one would be one that a vaccine didn't work against. We don't see any concern for that at this point. Number two would be one that makes people sicker. We don't have a lot of great treatments for this still. There's lots of work going on, but if people get COVID, they can get really seriously ill, as we all have come to know. So no sign of that either. The thing that is concerned is that it looks like it can be more infectious, meaning you need fewer viral particles, perhaps, to become sick. And that means that where people are lax on masking and social distancing, etc., we would potentially see more spread. And so it means that we have to just double down on the things that we know work. A masking, social distancing, these things work against the variant. It's not that they don't work against the variant, it's just there's less margin for error. And I do think in a more long-term way, if this variant becomes more predominant, which I think it likely will, based on what we're seeing around the world, we probably would need to get a higher percentage of Chicago vaccinated to get to that sort of herd immunity state. I think that would be the biggest real implication. It doesn't change anything we do right now, except give us one more reason for people to hopefully accept vaccine and to be just very careful, not let up on the things that have gotten us this far.
Thank you, Commissioner. And I think I'm glad that we have now a straightforward answer about we do know that it's more contagious. Around the infection with children, I'm very concerned today. I was reading the cover of the LA Times. Serious concerns around the infection in children around this variant. Do we have information about specifically around children in light of the reopening?
Yeah. So all of the data related to increasing transmission at this point has come from modeling data, meaning that they've looked at where are they seeing higher rates of infection, especially in the UK, higher rates of infection than would be suggested, right, based on sort of the number of cases. And in that setting, they've seen, they're just having a huge surge of COVID outbreak in the UK, and this is contributing to that. And so they have been extra conservative there in terms of all social, et cetera. We don't have evidence at this point that this is more infectious in children, any more than it is kind of more infectious in general. And importantly, there are still animal studies that are going on right this minute to actually understand how much more infectious is this particular variant, right? Like not just modeling, but actual kind of laboratory data on this. So the variant does not change at this point anything, to my mind, related to the mitigation things that need to be in place. It doesn't change a decision around sort of reopening schools. You've got to make sure that the good mitigation practices are in place. We've seen that those are broadly protective against the spread of COVID, but it's just again another reason to be particularly attentive to that virus. But they're not seeing major, it's more speculative at this point around children risk. It's all been modeled.
Certainly, I think, like you said, it is something that it doesn't seem to become evident one way or another, but definitely a reason to be extra cautious. The faces, right? I think that you have, and again, and I would agree that now more than ever it becomes important that we push efforts to get people vaccinated as soon as possible. On phase 1B, I know that you have between January and March, I know teachers are in that line. I'm extremely concerned about the reopening plan. I think that in line with all the variables that we see, what is the rush? I want to understand. It seems that we have vaccines, and I also want to look at the timeline. How realistic is the January to March timeline for essential workers? We talk about 100,000 of people. How can we? Are we realistically going to stay within that timeline? It seems that there's federal funding and others that I know that you are, I mean, that we depend on. My concern with all these variables is that what is the rush? It seems to me that there's a lot of risk here, and we're talking about thousands of people, especially.
Okay, so where we talk about 1B potentially beginning in January, we're only talking about the 65 plus, and we're only talking about it in the way that I'm saying, like if there's unused vaccine, healthcare providers can start to use it. Do not anticipate, because we still have tens of thousands of essential workers in that healthcare phase that need to get vaccinated. That is absolutely, the next couple of weeks is still very much kind of focused on them, but not wanting any vaccine to go unused. That's where we're likely to move ahead. So I don't anticipate us starting on that essential worker part until February. And there are settings that have been shown to be even, the very highest risk for COVID outbreak. Those correctional settings in particular are highly vulnerable. And so we're already doing healthcare workers there. We'll be starting on those correctional officers, sort of getting them going. Similarly, getting the EMS, the fire, I think I was talking about. We want to start for sure as soon as we are able to in these educational settings. But again, it comes down to how much vaccine we have. And you're right to say, how do we know the exact timing? I don't. I'm optimistically, the Biden administration is saying they're going to put everything behind actually increasing production here. We have to get more than 32,000 doses of vaccine a week. I have 360,000 people over the age of 65, and I have about somewhere between 300 and 400,000 of those essential workers that have been called out, 150,000 alone in education. So I am optimistically sort of hoping that we will be able to get more vaccine, but it's not like everybody's going to be able to get it all at once, even in that setting. So say we're able to start with education, I'm feeling optimistic, hopefully, later in February, really pick it up some more in March. It'll be a multi-week of getting these folks done. They then need to get their second dose, which comes a month later if they're getting Moderna. Protection is generally, that 95% protection is considered about, kind of a week or so after that second dose. So this is going to really be a rollout over the semester, and I want people to understand that. We are prioritizing, certainly, getting this group vaccinated, and that's why they are in there, and they're high in there. And if we get a lot of vaccine, it'll go faster. But that is kind of the timeline that we're looking at. I know on Monday there was a lot of conversation about sort of the CPS and the safety school part, so I'm purpose didn't sort of rehash some of that. But we do remain confident, and every day there's additional studies that are coming out that if you have these strict attention to the mitigation plans that risk mitigated, and as vaccine does come into those settings, along with the testing and the base things that are most important, they will become, even the risk will just continue to go drop down over the
In terms of accessibility, I know that we are partnering with pharmacies and others, other workers. Have a underneath, make sure that we're partnering with community-based spaces to make sure that once that people know where to go, that we're prepared, it's accessible, that we have the trust. I think that's a key component in making sure that we have trust and information that gets out earlier, right? I think we still have communities who don't have permanent care sites, right? Or so I think my concern is around the infrastructure that we have in place to make sure that the rollout is more effective, that it's accessible, especially in communities of color that have been, in my opinion, they still don't have adequate testing. Still a lot of work to do, and that's going to reflect our efforts for vaccine. So in terms of logistical efforts to have permanent vaccine sites that people know about, that they trust, I want to get a little detail. I know that you said that we can keep doing a dashboard. I do think it's important that we work with our offices and community-based organizations to have permanent vaccine sites that are accessible, especially in communities that be affected by this pandemic.
Yeah, so a couple things on this. One is that we do intend to, get as many of these vaccinating partners, particularly in communities of color, enroll and get them vaccine and get them going. It's part of why we started with FQHCs too, in terms of just thinking about that prioritization. We know that isn't everybody, but for people who are connected there, right, a lot of this is about trying to make sure we're getting, I do think people getting vaccinated begets people getting vaccinated. When people see folks that they know in their community getting vaccinated, it like helps drive some of that demand as well. Early on here, we really do want to make sure that where the city of Chicago, broadly, these large points of dispensing, we're using the big, the gymnasiums and city colleges in this first go around because we know that we can get a lot of people comparatively sort of through those spaces and their public transit and ADA and kind of all of the rest of these things. As we move on and there becomes more, we have more funding, so there's more ability to fund, and we have an RFP, once we have funding, that we'll be going to get additional people to help with the logistics part of vaccinating. We've been getting all of the schools of nursing and pharmacy and medicine, et cetera, signed up to be vaccinators and getting all of that kind of legal and paperwork done because they'll be important supporters in this. We're hiring everybody we can find who wants to vaccinate. We're looking at really building up that infrastructure. And I do think there will be the possibility of having some of these closed, closed pods, usually point-based, point of dispensing. And then further down the line, more like, some of this walk-up type stuff, but it's not going to be really at the very beginning. There's a lot of work, again, with the lessons from Protect Chicago, and we do anticipate continuing to use those workers and some of those approaches to make sure that people are getting the information and doing everything we can to be serious. We're going to be fighting this equity fight hard, like at every point. I just want to be really clear about that. When we surveyed in the second half of the year last year, we finished, and this was our formal Healthy Chicago survey that we do professionally, and it's how we follow a lot of health trends really across the city every year. We work to include some information about how likely are you to get a vaccine, and we saw white Chicagoans reporting twice as likely to report I am very likely to get a vaccine as Black Chicagoans and Latinx Chicagoans. And so we are putting, right from the get-go, a lot of thought and effort into that, interested kind of in your thoughts there. But getting the providers enrolled and getting them as much vaccine as they can handle and can push out the door, pairing that with getting these essential workers that have been hardest hit and getting vaccine to them is sort of the first part of this strategy.
I truly hope that we can address the issue regularly has been really a big issue. The testing numbers are very clear. I think that we got to make sure that we actually put that, it has to change around, it has to turn around. The issue of how we got to register people, how we're going to outreach, how we're going to do the facility. There's a lot of work to be done. And in terms of what it has been done so far, it doesn't give me the hope that this is going to change given what we have done so far. I do think that there's a lot of work that we need to be doing in collaboration, and that's my concern. For the registration of seniors, the essential workers were largely prevented in the pandemic. People of color who have, for numbers of 4,000 plus people who have passed away. We have serious issues of community equity. This has to be a fundamental part of our strategy.
Yeah, and I think, one of my biggest concerns, and this is where we've been sort of circling back, is that we're not seeing the vaccine acceptance, that we would hope for. And there's a lot of work, where we have made vaccine available to every single person who works in a hospital in the city of Chicago. We have made vaccine available to every single person who works in or is a resident of a long-term care facility, or will be. There, it's sort of happening over these next few weeks. But we are seeing a lot of people, particularly Black and Latinx Chicagoans, very hesitant in saying, I want to watch. I want to see my coworkers, get it and see what happens. And we're working to sort of shift some message that you're not saying no, you're saying not yet. What can we do to sort of make sure that we maintain it? Those long-term care facilities, we will keep coming back. Like, honestly, it's a lot of work, but there is no riskier setting in the city. And so we've been doing things like thinking about, incentivizing, giving stipends to healthcare workers, who are willing to be these champions. Probably more of those in the community areas where we're seeing lower uptake, less in some of the other areas that they can meet across the city. There is a lot that is underway, and a lot, again, I hate to sort of put it on the funding part, but we literally have plans. We're expecting we should get about $24 million to help support vaccines, hopefully very soon. We already know where every penny of that is going, right? As the more we can get sort of this funding, we can expand our ability to bring vaccines into community, and importantly, pair sort of trusted leaders in that community, whether that's you folks, whether that's religious leaders, whether that's healthcare workers, have that conversation and fund that kind of work. It's going to be a mix of a lot of this, and so we are, and the mayor has been very committed. As you know, sort of equity has been a major focus of this response, and will continue to be as we move ahead here. But it is going to be an uphill battle, and I don't want to sugarcoat that.
Commissioner, just to end, because I know my colleagues are away, I don't want to run out of time, but my last comment is precisely around that. For us to build trust in communities, for us to have a real strategy, right? Collaborating with different levels of government, federal, state, city, and county. I do think that at the city level we have to do a much better job engaging even our own colleagues, even people on the ground. This top-bottom approach is not working. I think that when you're saying we're going to pay these experts or workers, there's a lot of people on the ground, community, local officials who want to partner with you. We have to change. We see this unfortunate situation with the buildings in the schools. We cannot have hearings without educators. We cannot have plans for vaccination without community leaders, local aldermen. If we talk about collaboration and we talk about equity, let's not only say it, let's do it. Let's walk the walk.
Yeah, absolutely. And I do want to be, whether it's the Protect Chicago people, the Race Equity Rep Response team, many of you all, have been, will continue to be, want you involved, sort of in this. We do have to stick with, at the highest level, sort of the federal and state guide. That's not an option; it's a requirement, particularly where we're receiving vaccine free and making it available for free to our residents. I think the part that really demands this creativity is especially kind of on this outreach side. And I think the Protect Chicago work is actually a pretty, I would argue, I don't lead this work, right? This is not led here, but this work of sort of how do you pair citywide outreach with very targeted work and lowering barriers. I think that's a good approach, and I think it's high level, and there's a lot of people with a lot more experience who are working and planning this than me, and a lot of community leaders giving all kinds of input, whether this is about the sort of the COVID vulnerability and how are we kind of assessing that, to what should this messaging. There's been there's been focus groups, there's been reassessing messages, there's been developing it, pushing back out. There is a lot to do here, and that's where I was saying this work of sort of driving the demand is going to be the hardest work of this, even though it doesn't feel like the hardest work right now, because we're all hearing so many people who want the vaccine. The hard work is not just can we get the people in Chicago who are very excited about getting the vaccine, it's can we as a city, because we're not going to get past COVID if one part of the city is hyper-vaccinated, and we've got whole parts of the city that are very under-vaccinated. That actually doesn't get us past the city. So, to all of you, really challenge and trust and thoughts. I do not pretend to have anywhere near all of the answers on this. We have a lot of people and a lot of ideas and a lot of sort of minds and a lot of goodwill, I think, actually, in terms of people who are using innovative things and wanting to sort of partner on this. We're just wanting to make sure that, here is some information, and that's where, again, like we heard from a long-term care facility, you don't have stuff in Korean. You're like, you'll get stuff in Korean, right? Like, whatever. Like, where we can fill in gaps and help with that, give people the information, and then really use the power of, your offices and trusted leaders, and our healthcare workers. The reason I'm pushing so hard on not just saying, oh, we're done with the healthcare workers, is that high vaccination among healthcare workers is, in my opinion, going to be important for high vaccination in the city of Hunter. Thank you so much.
I hope those outcomes improve the outcomes that we have currently around testing and other what's happening in the real schools. It's all reflect dialogue. I hope those outcomes and our practices and how that we are.
Thank you. Alderman Marks.
Chairman and Commissioner, thank you as always for your time. Almost my colleagues have mentioned my face your team over the last number of months, including Mr. Martell, who's been out from our office. Just a few questions. One to start, I think a request through the chair. I'd be interested to see the list that you've been sending to the hospitals, and if there's something for specifically 47th Ward-based hospitals. I'm not sure how generally specific the list is, just so we can follow up as appropriate, because as Alderwoman Garza had mentioned, we've also heard about certain facilities that have excess, and I want to make sure that nothing's falling through the cracks on their end in terms of receiving, reviewing what CDPH has shared in terms of the facilities, the providers near them that they should make sure they're connecting with so that the vaccine's going to the highest individuals. Second, and this might just be a suggestion, to the extent there are weekly or regular emails from the mayor's office to city council in terms of some of the information like testing sites, knowing that that's going to, or not testing, distribution, knowing that that's going to be expanding very significantly on a weekly basis, that could be one of a number of ways to help keep us apprised in a way that is respectful of your time. So that's just a thought. Wanted to follow up on a point I think I heard you say about certain individuals in school settings who are deemed to be higher priority, the highest priority, nurses, for example. So when you're talking about nurses, certain other clinicians, whether it's speech language pathologists, social workers, are we considering them as falling within 1A from a vaccine distribution standpoint?
Yeah, that's a good question. Let me just hit on the first thing and then come to that in a second. So, yes, I think certainly, first of all, none of you are ever going to hear from a hospital again that they don't know what to do with vaccine as soon as we let them start vaccinating older Chicagoans, just to be sort of clear on that. But I want all of you to know that there is plenty of work still to do in 1A. And it's been odd to me where we're hearing from a hospital, I have vaccine sitting on the shelf, and I'm like, you have a list of, literally like 500 people that need vaccines. So we can have some follow-up there. I think particularly if there are some hospitals, I think, that are being a little louder about this, and if there are, we can do some I appreciate that sort of ask, just to help kind of clarify and push on that if there are ones that are giving you issues, because they're often saying something publicly that may not totally match. They've been very anxious to move ahead to older Chicagoans, as everybody is. Yes, thank you for that offer. I like the weekly email thing. We have this more general email that goes out regularly, but having more vaccine in this information, perhaps something specific to aldermen. So we'll think about that. Thanks. And then on the question about the the third one was the
1A.
Oh, within schools. Yeah. So broadly, this is about healthcare workers. It is supposed to be about healthcare workers that are seeing patients or are working in person. We are kind of making an exception a little bit for that with CPS, because obviously, right, they're only just sort of coming in. The highest priority there is getting the nurses done, because they will in turn likely be some of the vaccinators. We're using the school-based health clinics, right? These are sort of the existing settings that, are set up to kind of help support this. And it's been one of the main, one of the big conversations with CPS is like getting all of these logistics and kind of getting all of this sorted, even though it's not going to start from the lab. I think broadly, if there are these sorts of other healthcare workers, it's particularly in the schools that have been open, yes, they're healthcare workers. They can be prioritized within this group. What we're trying to do is similar to what we've done in, you think about our hospitals. They started with their staff, their healthcare workers, and then they sort of move on. It's the same idea. Like, we're going to send it to schools. You start with your nurses. You're doing maybe then the rest of your kind of health types, and then you'll be able to move as more vaccine is available into your other staff. And so it's about, again, helping these folks become vaccinator partners themselves, having all the information, and then we're not super rigid kind of about that timing. It's like you start with your nurses and you kind of move from there.
Got it. It's so fair to say then that they might be highest priority within, or among the highest priority in terms of 1B as it applies to education.
Yeah, exactly. And we will be, just like we did for hospitals and for everybody else, like what we basically do is we provide this guidance to a given, the archdiocese or CPS or a grocery store, right? Around here is how, we broadly would recommend thinking about prioritization, but they do know best sort of their operational stuff. We think about shifts, we think about locations, we think about this. We don't micromanage the exact details of how they decide to implement it. We work with them to make sure they have a good implementation plan. But if they decide it makes sense, except that we say, start with your healthcare workers and go from there. I would probably argue, starting from the younger, we provide some high-level guidance, we provide vaccine, and then the operationalizing of this in all of these essential worker categories is kind of done in partnership, and then they do have sort of that ultimate responsibility and decision-making. And that's how we want it. We want to make sure they are making vaccine available. And we're asking them now, and actually if you've got essential workers who are kind of anxious, some of this work now around some pre-surveying of their people, how likely are they to want vaccine, what questions do they have, building up some of that demand now, even starting, it is not too early. And again, we've got some industry groups that are working on this and BACP and everything else, but it's not too early to start saying, here are my staff that I know want to get vaccinated, right? Like, this is all sort of going to happen, and they can start working on some of that, and we're encouraging that within these industry groups, as long as they don't get confused so when they get vaccinated tomorrow. That's the kind of prep work that we're encouraging.
I have a few quick questions with regard to the definition of frontline essential workers. So I'm looking at page 10 on the presentation you had. Is that right now an exhaustive list of frontline essential workers? CEPH understands it. So going from correctional workers all the way down to postal workers.
Broadly. And there's a lot more, there's understandably kind of detail that fits within each of those categories. But yes, and again, we won't get all the way through 1B before we open it up. I can just tell that's what's going to happen. Based on I think the federal conversation, hopefully there will be more vaccine available. But yes, and we're working on sort of making sure these are kind of priority groups, right? Like, as we get to them, and making sure we've done some very specific planning, some very specific work to kind of get vaccine to these folks through their employers, and that it will start and then sort of continue as we kind of move 1B, sort of 1C. We don't have a lot of agriculture folks here, for example, but making sure that these are the groups that have been highlighted as being high concern for again outbreaks.
One of my colleagues, Alderman Cardona, sort of mentioned the issue with regard to libraries, and we've heard about that as well. We have a number of libraries in and around the ward, so as well as folks who live in the ward, even if their libraries are elsewhere. So I was wondering if you could provide through the chair maybe some high-level stats around whatever the most relevant incidents are, whether it's positivity rates or number of cases broken down by these groupings in 1B, and then how libraries fit in there. Because I think it would be helpful if you continue to communicate to folks to say, hey, these are the sort of incidence rates that we're seeing in the highest risk groupings within frontline essential workers. To our knowledge, this is what the data shows around librarians, and then, as to the extent residents have follow-up or questions with regard to those rates in terms of, well, I'm in this group that isn't in the highest risk collection, then we can follow up with CDPs accordingly. Again, just so they know, hey, these are the numbers that help inform the relative prioritization, knowing that, again, as you just mentioned, it's not going to be.
It's not. And we'll need to do a little bit of thinking about how exactly we can provide that. We do not have the occupation of every COVID case reported to us. But we do keep track, right, at the other level of sort of, what numbers of cases, particularly where they're city employees and some of what that is looks like. So we have to do a little bit of kind of privacy and just looking at a little bit of that. But yes, I think, we will be able to speak pretty clearly. We've done that already. And I think it's a good idea to do some more of that sort of within 1B around what has this looked like in Chicago, like why, where have we seen? We've seen a lot of outbreaks in these particular settings. We've seen a lot of cases in these particular settings. We have not seen a lot of outbreaks and cases in some other settings, even though they are settings of concern and they are important settings for society. So I'm going to take that kind of as a cue for my group to kind of get some data, because I think it's good for public facing anyway.
Thank you for that. And my final question is a little bit broader, which concerns, on the one hand, the general timelines that you provided in terms of the phases and when we can start to expect a transition from one phase to another, knowing that a previous phase that might not be complete right before we go to 1B, 1C, and the like. And while that's helpful, I understand that it's very fluid in no small part because of the work that is inadequate thus far at the federal level. So I'm sure as we get more clarity in the administration, hopefully at the presidential level, taking this issue more seriously and doing a more effective job in terms of helping produce more vaccines, how do you anticipate continuing to let us and the public know around these changing dates? And I think just to give a little bit more of a specific example, kind of question behind the question, with regard to CPS, obviously there's lots of concerns around how the reopening plan is going to work. And one of the things that we're hearing a lot from parents is, well, when will, and educators as well, when will this be available? And it's not just a question of course, when can we start transitioning there, but approximately how long it will take. So at what point will you start to see on your end, okay, the federal government, these indications from the federal government give me greater confidence in terms of how that timeline will look, at least I guess for purposes of this question, specifically regarding CPS.
Yes, okay. So at the most basic level, we need more vaccines. And I am hopeful, literally I think tomorrow we'll be getting the Biden administration's vaccine plan. That's what we're hearing unofficially, that it should be released. Knowing what that looks like would help, right? Like in terms of some projections and numbers, and then really seeing actual, number. And again, I try to bring people just sort of back to the math here, right? 32,000 doses a week, first dose of the week. Just in that 1B jumpstart phase, 360,000 over 65, approximately that many again in the essential worker side, and the Heppies have been working to kind of understand what that looks like in Chicago. 720,000, right? Like at 32,000 doses a week, and I know you've heard the mayor speak to this. Even if all the doses were going to Chicago residents, and 40% of them aren't, it would take us more than a year and a half to make vaccine available to Chicago. Like that is no good. Like we need this 3 times faster. So I really do feel hopeful that literally just in the next couple of days, as we get some more certainty about what our numbers are going to look like here, we'll be able to have some more clarity in terms of being able to project some of this out. I've just been very hesitant to promise promise a timeline that where we don't have vaccine, there's no chance kind of a meeting. So there will, I mean, and I know it's really this balancing line between I want to be very transparent about it. I don't want to confuse people. I want to give people hope that this is coming fast. I want them to understand this is not. We don't have any issues on like the distribution or it's none of that. It's about I don't know right now how much vaccine I'm getting next week, right? That is not a situation that lets us sort of like predict any of this out in a serious way. And I do think, and we've for those who may not be aware, Julie Merida, my predecessor, has been on the Biden transition team, and then Bashar Shukair, who was her predecessor as CDPH commissioner, is the vaccine coordinator for the Biden administration. So we have very direct lines into the people who are making these decisions at the federal level, and they understand very well what you need to be successful, especially at a local health department, and even more explicitly in Chicago. They know that it is good to trust local health departments to sort of understand what the needs are in their city and kind of give them some of that latitude to go. So I think we're going to see some more of this. I really do. And we're just balancing some of that timing against trying to be clear. And I know it's been these last couple of weeks. I know it's been hard on you guys. There's a lot of very, very valid questions, and nobody wants to hear I don't know yet. So more certainly, I think we will be able to, and even where I'm, putting some of those months out there, even those have changed, right, in the last couple of weeks. And so I want to be careful about not putting something out that is completely outside the realm of possibility, either too conservative or too aggressive. But if we know we're getting more vaccine, and if we know when the funding is finally going to get here, we can actually more realistically get some more details.
Good. Well, I'll be waiting like everybody else for those Biden
and we're
to be released.
That's right, and we're doing press conferences almost every day at this point, and we'll be pushing a lot out. And there is with this, and I'm not trying to pin it all on the federal transition, but I can't tell you how it's just been a different story every day, and I haven't yet seen more vaccine here. So as we hopefully see that, we can be a lot more specific in what we're able to tell Chicagoans.
Thank you, and thank you very much, Chairman.
Thank you, Alderman Martin. Alderman Espada.
Hello, thank you very much, Chairman. Thank you so much, Commissioner. This has been a really informative, helpful session for all of us. Hopefully these questions aren't duplicative. I wanted to ask first, with the percent of non-Chicago vaccine doses that are going out, there's really good news. Well, we see the percentage of our cases going up.
It's been going down a little bit. This doesn't surprise me because the people most excited to get vaccine in the healthcare setting are those with the most education. We see that true across all the predictor of whether people are saying they're very likely to get vaccine. And so there are a lot more higher paid healthcare workers, doctors, nurses, etc., who live in the suburbs and come in and work in Chicago. As we've expanded and seen more of the technicians, support workers, etc., we've gone from about 42% to about 37% most recent week. When we move to essential workers, when we are doing city employees and we're doing this, I do think that is going to continue to improve. There has also been conversation about if this continues to be a major imbalance, asking the state for additional, to reallocate additional vaccines to Chicago, right? We're going to do Cook County Jail. We would potentially, as may be needed, can Cook County allocate additional here? We're seeing kind of where some of that lands. Again, these people work in Chicago. I want them to get vaccinated. But I do think also that at the federal level, they're going to start not just looking at population. That has been a strong message from everybody. Look at what is actually, how are we doing in terms of pushing vaccine out? Where are particular parts of the country perhaps different in terms of having having more healthcare workers or having this or having that. And I feel optimistic that this is gonna be a success.
So Commissioner, CDPH is gonna vaccinate Cook County Jail rather than the county system?
So we are, so Stroger Hospital is in the city of Chicago. Cook County Jail is in the city of Chicago. Many of the people who work in those hospitals are city of Chicago residents. Many of the detainees are city of Chicago residents. So just administratively, to keep it straightforward, we sort of through Stroger and through Cook County Health, CDPH is not going to the jail and vaccinating. This is being done through Cook County Health, but we are providing vaccines. Again, Cook County has said they are willing to reallocate vaccines sort of to Chicago to help support that. But it's right. It's giving you a sense of like the layers under the layers under the layers, kind of about some of this. But it's a high priority setting. We were a little better set up to quickly get vaccine going, and we've seen a lot of cases there. It's a vulnerable situation, and we were ready to go. So that's how it is.
Yeah, I get that. I just hope that, as you say, like they take steps to help.
Yes.
Correct balance.
That's right. Right, and that's where we've been pushing on the state, and they've been good conversations. It's not like they haven't been good conversations, but it just started out more imbalanced than anybody expected.
So question number 2, going back 2 or 4, so back when you were doing the budget hearing, talking about the contract cases for you, you talked about the follow-up work of those contract cases, hopefully get the pandemic further under control, was going to moving into vaccine outputs.
And that is happening.
Can you tell us more about like what that role is? I'm really curious.
Yeah, sure. So, yes. So we have already, I think, a couple. I don't have the exact details in front of me, but there's at least a couple hundred of those folks that are already like directly moving into vaccine support, outreach, pods, all of this. And they are very much part of a lot of this kind of outreach planning. Of course, where you'll remember where we hired these folks were from some of the community areas that probably most need some additional work in terms of outreach and lowering barriers and doing the door-to-door and doing that kind of work. So yes, obviously a good portion of them continue to do the contact tracing, but we've already rolled and are doing the training, kind of getting them in. And I think starting next week, I don't quote me on the exact number, but it was at least 200 of them that were already going to be directly involved in vaccine efforts, and we'll continue to sort of balance that as we go. But yes, that's been our plan, and it's going well.
And are they like doing that pre-registration type of work that you were talking about?
But we're not doing that yet, right? So it's all been these healthcare worker stuff, but that's the kind of work exactly that we'll be looking for them once we're sort of in this phase to be doing. Right, initially it's about making sure they have the information, literally supporting in the pods, like getting people checked in, like not vaccinating anybody, of course, but like doing some of that work, as well as we've got them doing some of the outreach around where do we have healthcare providers. We're asking you to help with that, but also the chambers. There's been a lot of especially in the neighborhoods where we want to get, because not everybody says yes, right? We reach out to independent pharmacies and they say, no, we don't really think we're interested in that. We're like, what can we do to help you support around this? Where can we do, not just sort of taking no for an answer. And but yes, they are definitely part of the plan and already getting.
Okay. 2 last questions. So it sounds like the 1B part that is vaccinating seniors 65 and up could start very shortly. Is the vaccination of, and again, always vaccine dose dependent, but is the vaccination of essential workers going to follow the vaccination of seniors, or will they be happening concurrently? What can we anticipate?
They'll be happening concurrently, but we're going to open the 65 plus first because we're going to frame it as where healthcare facilities have unused doses, they can use them in this 65 plus. We are still very much in the 1A essential workers. and expect to be for another couple of weeks at least. I would say another couple of weeks. And then after that, we'll be expanding sort of in more of those mass vaccination. But really the city work is going to be, and when I say city, like big CDPH stuff, a lot of that is going to be more focused on the essential worker side, bringing vaccines to employers and then bringing people who are small and less connected to pods. And most of the over 65 work, is going to be through pharmacies, clinical partners, urgent cares, and then work of getting them connected. So that's kind of at a high level. That's where that's going to be. We don't anticipate starting on the essential worker side until February. In a serious way, although again, correctional officers, it's sort of moving, right? This public safety is sort of moving. We get it started and we just kind of keep feeding vaccines. So it's not as much of a bright line as I think people sort of imagine. And this works like airplane boarding, if you haven't heard me say this. If you didn't get on the plane when your group was called, you didn't, the plane didn't leave yet. You still sort of get that top priority that like if you were a hospital-based or a long-term care facility worker and you didn't sign up first, when you say I want a vaccine, like you get a vaccine. And you sort of, at least right now, that is where the priority continues.
Final question. And I know that Alderman Martin, Alderman Cardona have made this case related to library workers, and I agree with them. Folks who have not, who are public facing, who haven't even had the opportunity to work remotely for tasks that could be done remotely, feel essential. They feel essential. My question is not so much related to that, but we heard from one of our library employees that at least one of their staff members had been pulled off, they were told, to staff the CDPH vaccine clinic. This sounded like a very strange thing to me. Can you give credence to this one way or another, what they might be thinking about?
Yeah, I'd be happy to. So there's a few things that are happening. One is, as you can imagine, we are getting inundated with public questions, right? And so CDPH, for months and months and months and months, we have a lot of staff that are just designated to answering individual Chicagoans' questions, and we work in partnership with 311 to do this. We've got volunteers. It itself is a very large operation. And I know that there has been some, I think, library volunteer types to kind of help support on some of that. Also, though, just coming back to the point of we haven't received money yet, we are staffing some of these city pods with volunteers across city agencies right now. So not vaccinators. CDPH is of course working to make sure that we've got the nurses, like not the people putting it in arm, but it's a lot of people. So like the lines and the registration and the monitoring and making sure people have what they need. If you're talking about moving hundreds of people, even 1,000 people through your site, that takes quite a lot of people. And so we have had people from water and finance, and maybe there could be a couple from libraries, that have been working in some of these settings. People who work in pod settings, vaccinating, are also offered vaccines, to be clear about that. The way it works is you vaccinate the people. There's always some people who don't show up for appointment. We have a few extra doses. We offer that vaccine to people who are working in the vaccination pods. We also think it's important from being able to, answer questions, confidence, all the rest of it. And so if there are people who are working in our vaccination pods, they are also offered vaccine. You'll see they're noted in that 1A group. So yes, so there may be some truth there to what you are hearing, but that is a volunteer situation. And we've told city workers, I need people to staff this, right? And so, again, we've got an RFP, we've got more plans to sort of do much, much more with this, but we don't have a lot of staff, and we feel strongly about getting this up and going as fast as we possibly can. And so there's been training, and this has been through OEMC, to really have people step up. There's no particular training that's needed. It can be just-in-time training. It's things like line monitoring and some of that, but it requires people. We anticipate that will no longer be necessary really by mid-February. We expect by then there will have been more funding that's been available, and we'll have more capacity to do this. But even for our CDPH team, we have sort of said, I've said come one, come all, basically. People who can help volunteer, to be part of these teams, to do the training. not forever, but for about the next 6 weeks, we have taken a huge number of CDPH employees and moved them to this because I don't think there's anything more important than jump-starting this particular effort. Even as more down the line, we'll be able to kind of expand it out a little bit more. So.
This is helpful context, in part because there was concern, even with the layered mitigation review, that increased exposure could increase their risk that then was translated brought back to the rest of the team. Knowing that they also have the opportunity to be vaccinated while they're serving these nurses is very helpful for me to understand. I appreciate that. That's all my questions for now. Thank you, Commissioner, and thank you again, Chairman.
Thank you, Alderman King.
Thank you, Chairman. Thank you, Commissioner, for being here today and for the work that you and your staff have been doing. I'm sure, as everybody else has indicated, it's been more than your share, so we appreciate that. I'm just concerned kind of about the distribution and equity of distribution. If you look at the map of where folks who've gotten the vaccine, it's not the same overlay or representation as where we saw the outbreaks. And so, I asked your staff about a week ago, where were the vaccines distributed and how many? Do you guys have that list?
Yeah, so we do. And again, those maps reflect
Is that something that we can get readily? The list of where and how many?
Let me. It is not. I mean, if it was a very easy thing to provide, obviously we would provide it. What we can do, and again, those maps reflect where people live.
Right.
Right. And so those maps. And I'm not. Had I shared with this group where the different types of healthcare workers live in the city of Chicago? Had I shared this with this group?
I don't think so. That was going to be one of my questions. Do we have a map of where healthcare workers, not just workers, but the whole staff, right? Everybody who is eligible in this 1A, kind of where they live, because that may give us perspective, right?
Yes, exactly. And if you look at that map, and if you look at the difference between where, and we will definitely follow up and send you this. If you look at where what we call the diagnosing and treating healthcare workers versus sort of the technical versus the more support, and that's a federal designation lives. The way the map looks now, it matches very much better the diagnosing and treating. And that is reflective, meaning the doctors, the nurses, the higher paid, honestly, folks, less likely to be Black and Latinx, which is also reflective of what our hospitals have told us related to uptake. We've seen some of the best uptake in the city, honestly, in some of the small hospitals that serve heavily Black and Latinx. Some of we started in a ceremonial way, right? At Loretto and Norwegian and St. Anthony's and some of these have actually seen better uptake of vaccines sort of as a percentage across their staff. What we've seen in some of, but they're smaller numbers of staff. It's really in a lot of our large healthcare systems that have thousands and thousands of employees. They maybe have not done as much of the sort of one-off, like let me have a conversation with every person on the staff and follow up and make sure that the support healthcare workers are also sort of getting that vaccine where we've seen some of that lagging. So
is the map reflective of those support healthcare workers as well?
Yeah, there's 3 maps. I will send them.
Okay, great.
Yeah.
I just want to understand, because of the equity piece of how it's distributed. And then, so you distribute it to major hospitals. And let's just say you're not a major hospital or you're a clinic or something, but you've got healthcare workers. How do you then access getting vaccinated?
Sure. So, every single hospital, specialty, safety net, large, small, in the city of Chicago, has gotten all the vaccines that they have asked and continue to get all the vaccines. So, just sort of as a starting point. Similarly, every skilled nursing facility and assisted living facility and then a good number of the behavioral health, residential, et cetera. 250 of those.
So you're saying they have gotten all the vaccines that they have asked for?
The hospitals, yes.
No, I'm talking about like the smaller clinics or.
Yeah, I didn't get the things yet.
Yeah,
So,
that was the question.
Yeah,
Yep.
right. Hospitals have gotten as much as they wanted. The long-term cares are all basically taken care of in the high priority. The clinics, this is where when Moderna became available, 74% of Moderna doses had to be allocated to long-term care. So we've had a relatively small, just 20,000-ish doses that have been available to go to outpatient providers. So we started about a week and a half ago doing some direct distribution to these outpatient providers, starting with federally qualified health centers and outpatient health centers that were seeing a lot of COVID cases, that they were doing COVID diagnosing, doing a lot of COVID testing, and then have been similarly enrolling the pharmacies and the urgent care. That is what is now up to over 250, just over the last week and a half, and that we're adding sort of dozens kind of every day if we want to get more. So we can provide that list to you, and I want to do that.
Yeah, I'd like to see that, but I'm concerned because I do know some clinics that haven't gotten it and that they've asked for it. So from an equity standpoint, I mean, their doctors, their staff, so I just want to understand, how to access it and how we're prioritizing that, based on kind of the zip codes of where the outbreaks were. And I if we aren't, I suggest that perhaps we do. Or what I'd like to kind of understand, and part of my question is some of the bigger hospitals who've gotten, maybe more, what is their accountability to prioritize? Is there? I mean, can they just say all the doctors come first, then we're going to get the nurses, then we're going to get the staff who work there, then we're going to get, how do they prioritize it? Or is there not? Or do you give it to them and allow them to decide?
Yeah. So on the point of outpatient providers, this is where we need them. There's just certain kind of paperwork and enrollment that has to happen. So we have been prioritizing our outreach. Well, first of all, we started with federally qualified health centers and any of our settings that we're diagnosing a lot of COVID. Like if they're doing COVID testing, they're seeing a lot of COVID patients. That was how we started in terms of prioritization. And then looking at the zip codes that are already approved. And there has actually been quite a lot of work looking at both sort of at a citywide level, where, what are the risk factors, everything from low primary care physician to low English proficiency to higher, Black and Latinx to socioeconomic, like there's these sort of root cause things, and then we've looked at our COVID outcomes. So we've looked at COVID case rates, COVID death rates, COVID hospitalization rates, and done sort of a composite there to say where are our most sort of COVID vulnerable communities, and then because 1A has been about healthcare workers, we have to make it about healthcare workers, right? Like they're just being available. But we've been working to do additional outreach in the highest CCBI, these high, more vulnerable community areas, to get those providers enrolled. And then especially as we move ahead, there will be additional opportunity to push additional vaccine to providers in the higher COVID vulnerability index neighborhoods. And then a lot of this more outreach type work coming down the line. In terms of hospitals, so we don't regulate hospitals. We gave, and if anybody's interested in what, everything that we send to hospitals is publicly available on the Health Alert Network website.
So you gave how many vaccines you sent to them? That's available?
Oh no, it's not because so I meant the communications around here.
So
yeah, yeah, but what is a little bit complicated? The reason I'm not trying to. Often, what goes to a hospital system gets redistributed to its partner clinics or even across the hospital system. So, like, you take, like, the Advocate, like, we're sending all the vaccine to one of their facilities, and then they are redistributing it to the Advocate's other hospitals. Or if you take, do you know what I mean? So
I know what you're mean, but then how do you prioritize areas that have been hit the hardest if you're allowing them to do that? That's kind of what I'm getting at.
yeah, so we'll be able to prioritize again. 1B is really 1A has been only about settings. You must make it available to healthcare workers, and you must make it available to long-term care facility residents and staff. Right, like those have been the top priority. Making that available to everybody who fits that category in the city of Chicago is the top priority in 1A. 1B,
Are you saying that does a healthcare worker include people who work in a healthcare setting?
Yeah.
Okay, so that's everybody.
That's everybody. And so that's where these unaffiliated healthcare workers, that's been the main thing that we've been working on. Once the hospital about a week and a half ago said we're seeing this start to slow down, they were starting on second dose. Really this focus on the outpatient health providers. So we've got more than 800 of these dental offices, right? Like across the whole city that we're connecting to hospitals, connecting to pharmacies, connecting to our points of dispensing.
And how are you connecting them?
So there's literally I gave you that one website just to try to keep it relatively limited.
Right, but I know folks who have gone on, and so they're still wondering, okay,
yeah,
do I go to the nearest hospital where it's distributed? Does the hospital then call me back? How do I get on a list?
Yeah,
it's been a little challenging.
So this is all being done by employers. So there is no need for an individual health care worker to sign up for anything. What we've done is all of these, everybody who is a licensed physician, a licensed dentist, a licensed mortician in the city of Chicago, got letters and information, and then we've done follow-up where we weren't seeing it, to let us know. There was a survey that was like, how many healthcare workers do you have? Tell us about, what are your needs? Where are your places? Are you interested in being a COVID vaccinator moving forward? And if they're interested in being a COVID vaccinator, or they're in we have about 400 that are in our regular vaccinating partners. We've been working there to get them vaccines directly to start with vaccinating their own healthcare workers. The most of these are not going to be vaccinated. The home healthcare workers, the PTs, the dentists, the morticians, the dialysis, they're not going to be vaccinators. That's who we've been signing up. Basically the way it works is your practice, there's one point of contact for each practice, and they get the notice, your practice is open, here's your code. They get a code, and then all of their employees can use that code then to register for open appointments in our pods, in the pharmacies, in the hospitals, and we've been really working to pair hundreds of outpatient providers with especially the hospitals that may be nearby them. So hospitals this week have been vaccinating dialysis centers and outpatient practices and home health, et cetera, as have we, at the Malcolm X pod and these other pods that are sort of opening up. So if there are still healthcare practices, that aren't enrolled, it's all on that. And if you go to the main vaccine, try.gov, COVID vax, there's a healthcare provider tab that has a lot of detail about this and sort of what they need to do.
So they get enrolled and then they receive something back that tells them immediately where they can go to get vaccinated.
It gives them a code that then lets them register for COVID appointments. So it lets them.
Where do they register?
We have an appointment system. It's called VCMS. It has all of the appointments that are available at the City of Chicago pods. It has all of the appointments that we're making available through pharmacies for healthcare workers. And it has appointments increasingly where our hospitals and our outpatient providers are able to do that.
Now, not all of them have. If I'm one of these clinics and I get this code and I go somewhere else where it shows me a list of where to put this code in.
Yeah, you basically say you can get a COVID vaccine. You go if you've ever signed up to get testing through us, it's like that. It's here are all of the available slots. Choose one. What works for you? Here's where they're available. They're at Malcolm X. They're at Arturo Velasquez. They're here.
Once you choose one, then you get what?
Then you have your appointment. So you get an appointment that says on January 27th at 10 a.m., I am getting vaccinated at Malcolm X High, or at Walgreens Pharmacy here, or at whatever.
Okay, I've had a couple dentists that say it's not as clear cut, but I'll.
No, it hasn't been as clear cut because you haven't, right? It's literally just been in the and this is the question. If you have people register too early, then they're worried that something hasn't happened. You know, we let them start putting in this information in the end of December. We asked them to have filled it out by January 1st. And then we really started matching them in serious ways over the last week or so. There are more than 5,000 individual practices that have been registered, more than 160,000 employees. We're down to about 66,000 that still need that connection, so we're getting through them quickly, but there are plenty of practices that still won't have received that, and that's why we're not done with 1A. And that's why our top line messaging is that even as we start to open to 65, our priority is making sure that those outpatient healthcare workers who are reflective of our city too, especially where you start pulling in home health and some of these other ones, we want to make sure that they are getting prioritized for vaccines.
Sure. And I would just encourage you guys to go back and look at, kind of the outbreak and where some of these kind of clinics are, maybe in smaller neighborhoods, to make sure that they're prioritized, because if they're not vaccinated yet, I think that speaks to equity as well.
Yeah. And every and again, all the federally qualified health centers and anybody who's had a high level of COVID, that they are doing COVID testing and reporting, as long as they've gotten their paperwork done. And this is, again, I know it sounds sort of arbitrary, but they've got to get that done before we can send them vaccines. So we're working to get all of these people enrolled so we can send them vaccine, because we completely agree. Like in these hard-hit areas, they're our highest priority for getting enrolled, because they're going to be important for us to be able to sort of, vaccinate travelers.
Yeah, and then the last thing that I'll leave you with is, you talked about the cards, that everybody gets the cards. As you move through this process, I know it's evolving, but perhaps you could think about, using the cards as kind of a bottom up, right? So folks who have the cards, who are in the areas that were hit the hardest, have the priority, and kind of go by there, versus giving it to, big hospitals and saying, hey, you guys be responsible for distributing, because I think there's inequity in that sometimes as well. Just a thought, it may be harder, but I'm just really, as you look at the website, it's very stark. It's almost an opposite of where the outbreak was, of who's getting vaccinated, and it's just
Yeah, and the other just piece I just want to kind of highlight is that one of our problems actually has to do with the logistics of this vaccine, because this ultra cold is just not widely available. Most of our hospitals don't even have it, although they increasingly are. And so having more of this Moderna vaccine and additional vaccines that come on that a regular clinic can handle with a freezer and a refrigerator is also kind of part of this. And so we've been working to try to have the hospitals be these vaccinating partners and link, and there's going to be a link up of them, and not letting them sort of do kind of come one, come all, because that's not going to be successful. But that's where getting more vaccine and getting these outpatient providers are going to be the heart of our vaccine effort.
Just to clarify on the storage, I thought that was just the initial, that you have that 5-day, period where they don't have to be stored at that high level. Can you clarify that?
That's right. You have to use all of the vaccine within 5 days of when it has come out from the ultra cold freezer.
So that gives you that landing period, and shows us perhaps that's distribution to places that may not have that type of storage.
Yes. The thing, but from a sort of ability. So say I'm a clinic and I want to be able to, particularly in these hard-hit areas, I want to start being able to vaccinate, my highest risk people, anybody over 65 who's coming in. it is operationally much easier for me to have vaccine in my freezer that I can be pulling out and using for all of these patients as they're coming in and coming through than it is to sort of stand up the separate vaccine clinic. So we are using Pfizer. Everything the city of Chicago distributes is Pfizer, and so where we're doing strike teams, that is all Pfizer. We can handle those logistics, but it is a lot, honestly, for these littler clinics to give them a vaccine, all of which must be used within 5 days. We got to make sure we don't waste vaccine at certain top lines.
Sure, we've got to manage it. I just don't want that to be an excuse for not having equitable distribution. I have a feeling within 5 days they could fill up and, make appointments and have that ready, to go and really from an organized standpoint. So I appreciate your time. I just, hope that you guys will really look at the equity lens because, this is really important. I know it's important to the community. So just to kind of look at that and where it's going right now.
It's the piece I'm the most concerned about of this whole thing, honestly.
Right.
Because we're all gonna be pushing. I mean, there's a number of things that are set up that barriers are higher, and it's everything from initial sort of immediate acceptance, there's work there, the logistics, where are there more places to vaccinate that are kind of easy, what do we do to support that? So, kind of in the same way for testing, we've looked every week at the data and then worked to push city resources, like where they're most needed. That is what we'll be continuing on here, but I completely agree, and we will be oversupplying. That's how this is set up. That we will be oversupplying vaccine to outpatient providers in areas where we are seeing less vaccine uptake.
One last quick question: when will we get that distribution list?
By distribution list, you mean who is enrolled to be a provider? I will have the team run it today.
Where the vaccine has been distributed so far, and how many? Yep.
Yeah. So what I could provide today is the breakdown of hospital, but we'll provide what we have. I just need you to understand that in a lot of cases, what started at one hospital moved. I don't have a hospital by hospital full-on breakdown available. We just don't. It doesn't come through the data that way.
I'm sure I'm sure you guys know where exactly these have been sent, since these vials are really precious. I just want to know where it's been distributed. That's all.
Okay. As long as you recognize there's a lot of redistribution that happens after that. That's the only.
Sure, and I hope we're following that. That's all I'm saying. I'd like to understand that because of the equity piece. It's really important. And I do have clinics that have registered, that have emailed, and haven't gotten it.
Right, because there's only been 20,000 doses of vaccine that has been available to send to outpatient clinics, right? And so, again, we had 5 outpatient clinics a week and a half ago. We have 250 now. So it's going quickly, but that's why we're still in 1A, right? For everybody who's like, I got to do 1B, I got to do 1B. We have 400,000 healthcare workers in the city of Chicago. We have received 59,000 for long-term care, 100,000 basically of everything else. I still have 250,000 healthcare workers who have not been vaccinated. Some by
I understand that. I'm just saying let's look at it just from an equity lens, even within that distribution hierarchy. And I'm saying there are people within that 1A who are in these areas that have had these high outbreaks who don't have access. So I'm just wanting to make sure that we look at that.
All right, I'll have the team pull what we're able to pull. Again, there are some hospitals that their computers still aren't talking to each other. So, but yes, we'll pull what we have.
I just want to know where you have distributed it.
All right, guys, I think we got it.
Where it's gone. I think that's important. That's all.
All right, I got it. Thank you all.
Thank you.
Alderman, Vice Chair Kappelman.
Thank you, Chair. Dr. Already, I'm just so proud of what the work you're doing, and a shout out to Alfonso Martel and your whole team. It's great. When I go to the website and click the tab COVID-19 vaccine, I can click on FAQs and go to the tab labeled "Can I register to get the vaccine now?" People are hyper focused on getting that, and I understand we have the 1A group first. But it states there is currently no public registration for COVID vaccine at this time, which I understand. CPH will update this website with registration and clinic information and additional groups recommended for the vaccine. It might be helpful to also add that CPH anticipates when you anticipate this information will roll out. As you can see, there's an incredible lack of trust about this for multiple reasons, and that might help with a time frame.
Yeah, and I think we were talking about this internally too. There's just a lot of people are worried they've like missed something, and so I think we're probably going to re-up again. I had them look at the language, kind of try COVID codes. That's like you can register here. We will absolutely be texting you directly and letting you know, like for these people who are very motivated around when it's available, so that people who are really there hasn't been anything that you need to sign up. There isn't. It doesn't help you jump the line. But to give people who are very much feeling like they want to kind of sign up, I think we were talking about this internally too. Kind of re-upping that a little bit, and then say that we will continue to, as we have been, sort of communicate directly to people who have registered through that link, just with updates about COVID.
Great. And we'll deal with a lot of people's anxiety and fears and lack of trust.
Yeah.
I told my primary care physician last Saturday, everyone should have a primary care physician. I worked at Access, undocumented, no insurance, still everyone should get health care. And my physician is not sure yet about the notification of the rollout, how that will occur to patients. So should I be encouraging people to contact their health care provider who will notify them about when they can get the vaccine, or is it that the health care providers will be the ones taking the initiative to notify their patients?
The healthcare providers will be taking the initiative. We will literally be communicating probably, and again, this is in the context of just sort of what's coming probably next week. Specific instructions to healthcare providers in Chicago. Again, if you've got a healthcare provider who feels like they're not in the loop, they got to make sure they're registered for our HON, the Health Alert Network, and everybody gets the same information sort of at that same time. Again, this is not come one, come all, 65 plus. This is where healthcare providers have unused vaccines can start, doing their older patients. So that's where we are.
Good, and this will encourage people to have a primary care provider. And every adult should, every child should. Trust about the rollout of the vaccine. We're also getting a lot of calls from people who say they know people in other states who have gotten the vaccine sooner, the people in the 1B category. I would suggest maybe some communication about why the rollout might be different here. Again, it addresses that lack of trust.
Yeah, and I think to the point someone was suggesting some more background on kind of what 1B looks like in Chicago here, why 1A is just a lot bigger group here than it is almost anywhere else. We're pretty unusual to have such a large healthcare, like we really are the healthcare system for the whole region here in the city, and that makes our 1A bigger than it otherwise would be. And we have a lot of people who work in healthcare who don't live in Chicago, and we're doing all those folks. So yeah, we can put, I think, some more context around that. Makes sense.
And then the last thing, so I'll keep it short, great questions were asked beforehand about vaccines and aldermen. There are pros and cons for having aldermen get the vaccine earlier than the general public. Because I want to do everything I can to encourage them to get a vaccine. But at the same time, I don't want to communicate that city officials get greater priority because we're more important. That's going to make a lot of people very angry. So whatever the decision is, I preach to the choir here. I want to be based on evidence-based best practices. What really works to get people to get that vaccine? And if that means getting aldermen ahead of the line, that's fine. But I have some suspicions that's not the way to go about it. But just letting you know.
Yeah, no, it's been a major topic. I mean, not just for the aldermen, but for sort of, I mean, the good thing is certainly we will have an opportunity very soon here to highlight a lot of very prominent Chicagoans who are 55 plus. Like that will for sure be a major thing that happens.
Especially black and brown.
Exactly. But then about this, and to your point, we actually have asked the team to sort of look into, what do we know about this? Great. Mostly just want people, yourselves, if you personally are having questions or hesitations, if we can help kind of address those, because I do think there will probably be some power in this group, sort of collectively, doing this, or the majority of people. But yeah, I agree. There's not a very straightforward decision in terms of, and it extends to, we don't want to just, it's this balance between, yes, I want, the number of times people have asked me, when is Chance the Rapper going to get vaccinated, right? When are the Bears going to get vaccinated? Like, there is this mix between wanting to sort of show confidence in the vaccine and people that folks sort of look to as role models, or really want to see what they think, that importance of kind of celebrity influencing on that is balanced against, well then why does Chance the Rapper and the Bears get prioritized above other people? And we've done a good job, I think, in 1A of saying, like, there's a lot of people who are a lot higher risk, and like this is why we're starting with this group. It's as it opens up here that you are doing some of that balancing and some of that thinking. But we really, we consider you all also actually important figures, with kind of that prominent piece around when you make the decision to get vaccinated, supporting kind of that public messaging of that. But it is balancing this against these other people.
Thanks. Just as I publicize my flu shot, I will publicize it when my turn comes.
Exactly.
All right. Thank you. Thank you so much, Chair.
Thank you, Vice Chair. Alderman Rodriguez Sanchez.
Hello. How you doing, Commissioner?
How are you?
Good to see you. There's a lot of really good questions that have been asked already, so I'm going to keep it short. I did step away for a few minutes in two instances, so if somebody already asked about this, I apologize. As you know, I represent a very diverse community, and we have a lot of people who speak a lot of different languages, and I would like to be able to do sessions that are in different languages to educate people about the vaccine. Our community particularly has a lot of hesitation around the vaccine. My mom is one of those people, for example, and I want to make sure that we have information accessible in different languages, but also I guess that is appropriate for different ages and different experiences, I would say. Like, I don't think that I would talk to my mom the same way that I talk to, or bring, similar information. So I wanted to ask you about your thoughts in terms of being able to reach as many people as possible and as in-depth as possible, right? Because sometimes one thing that I struggle with is that even when we are able to have other languages available, the depth at which we are able to express the content is not as deep, right? So,
doing a lot of work on this. We're particularly prioritizing Spanish, trying not to sort of leave the others aside, but working hard to make sure that, whenever we're doing kind of, with the city, I mean, CDPH, doing town halls or kind of larger sessions, and there's a number of these going on, particularly with partners, that we're making simultaneous Spanish translation available kind of in that moment. We also, one of the medical directors at CDPH, who is fluent in Spanish, Latinx herself, has been doing a lot to make sure that where we're doing videos and science behind the vaccine, all of these things, she is doing those also in Spanish. And we've got we've got people with regular Univision, spaces and regular spots on WBON and regular spots on, and a lot of the sort of larger, more, focused media channels, particularly for Black and Latinx Chicagoans. And I think, in terms of the focus, I think that's actually a very good call because we're doing a mix of sort of big events. Like, I don't know if people saw, we helped sponsor the big event, last week. It was a national event. Dr. Helene Gale was the only one on it from Chicago, but it was about sort of let's talk about the vaccine for Black Americans, and did, that got about 350,000 views, and we were able to, put that on sort of all of our social media feeds. And like, where there's some opportunity to focus a little bit more, that's kind of the big high level. I want to take advantage of where there is good work that is naturally happening, as long as it's in line with all the public health guidance, but then supplement that with more specific. So we take long-term care facilities. I've been very concerned that we're seeing low uptake, particularly among staff at long-term care facilities. And so we did a series of focus groups. What were the questions? What were the concerns? And then did a series of directed kind of long-term care specific, like this is only for people like, in long-term care, let's take your direct questions, let's get this. And I think increasingly, sort of neighborhood specific things, as there are more people who have been fully vaccinated too. And we're making videos with healthcare workers who live all over the city and can kind of talk about why they got vaccinated, and trying to do some more of that. So, there was a lot of things, but I think this targeted, if you remember back at the beginning of, with the Race Equity Rep Response Team, we did a number of these, like, sort of community-focused conversations, that we liked that idea again. We kind of charged the Protect Chicago team with doing some more of that, because I think that went well. Bandwidth, money, and making it happen. But yeah, it's in our plan to do, in addition to the high-level things, some more targeted, whether that's by community area or by particular group, and have the opportunity.
And I think you have mentioned before that CDPH has a lot of people who speak a diversity of languages, and you were thinking about deploying those resources in order to be able to get access.
That's right, and we've been working. We've developed sort of a kind of vaccine 101, right? That can kind of be available, and then I'm working to kind of get folks trained here to make sure that they can. I'm always comfortable sending my doctors out, but I want to make sure that across sort of the health department, I have people who can help. Because there's a lot of, which is a great thing. There's a lot of asks for people who can help, but I got to make sure that people are providing the right information. It's in the right message. And so building that sort of Bureau of Expertise and looking to our community partners. We've been doing a lot of work with RERT and others, like developing materials, making it available. You'll know everything on our website is like, you don't have to ask us, use it, adapt it, go for it.
Okay, that's good. So I have one more question. I've been reading a lot about the vaccine, and I don't know if you already covered this, and if you did, I can talk to you offline. But I was reading about the vaccine and about what will life be after the vaccine. And, I think a lot of people are expecting that once you get the 2 shots, we're good. Like, we're going on vacation, or and I would really like to make sure that communities understand that this is going to be a process. And so I don't know if you already covered that. If you did, we're good. But I do want to start having the conversation about what to expect, because the idea that we are going to get the shot and everything is going to be normal again is not right, and I would like to have a little bit of insight into that conversation.
Yeah, that's right. And we've been working, pretty much every time I ever speak publicly, we talk about it, the mayor, et cetera. But it is one of the things that I think there is the most. Right, there's this feeling like I'm totally done, and even a vaccine that is 95% protective, which is fantastic as far as a vaccine goes. First, you're going to need 2 doses of post-vax first, but even that, that does mean 1 in 20 people, like in this trial, still had the possibility of getting COVID. And when we have a lot of COVID still around, right, like we're a very long way from this herd immunity, there remains the need to sort of as a community continue to do this. Your individual risk goes way, way down, but it is not zero, and that's part of it. And that there are still ongoing studies. We know that the vaccine is very protective against symptomatic COVID, moderate, severe, et cetera. And there's preliminary information, particularly from Moderna, that it is also protective for the asymptomatic. But there's a real question, there are still questions around that. And so every vaccine that somebody takes in the city of Chicago, does move us closer sort of to that goal. But it is going to be months from now before we're really at a point where we can say, you know what, we're going to be able to start relaxing some of this. We confident in that unless something major.
Right.
Violated.
So when you talk about talking to people in terms of the education aspect of the vaccine, that is also going to include what does it look like after you are vaccinated, and what can we expect individually and collectively after we go through, a mass process of vaccination.
Absolutely. And it's been one of the more interesting things. We've been doing a lot of conversations and focus groups with obviously healthcare workers and, what are your concerns? And there was this major concern around if I get the vaccine, I won't get PPE. And we were like, no. Like, you still get all the PPE. You have to keep using the PPE. PPE is not going anywhere right now. This is an extra set of protection. So, right, I think, there's some nuance kind of to this. And so this is where a lot of the work of kind of, like, you get people who are honest with you about why they or their colleagues are hesitant, you can actually kind of tailor some of that messaging for those groups. Also in the long-term care facilities, a ton of people have had COVID, right? And so you have to emphasize that, like, the part about even if you had COVID and you recovered, here's why the vaccine is still recommended. It's just different, like, in different settings.
Right.
So, yeah.
Right, and then one more thing, I was also reading about the different versions of the vaccine, and that there was one that was being developed that is going to be a lot cheaper and that is a lot easier to store. Are we going to be getting access to that? And are those conversations that we're already having with the incoming administration of Joe Biden?
Yeah, so there are about 50 vaccines around the world that are still in trials, meaning that they're still being tested for safety and efficacy. The two that are sort of furthest along here, besides the two that have already been authorized, are the AstraZeneca one and the Johnson & Johnson one. The Johnson & Johnson one, both of these are much less expensive, which is not a concern really, but internationally that's a big deal. But they also, the Johnson & Johnson one in particular, is a single dose, which would put our logistics, right, it literally cuts our logistics in half to have a vaccine that would be protected with a single dose. And if you only need refrigeration, that majorly expands our ability to make vaccine available in less traditional settings or in lower, like, even freezer is quite a bit harder than refrigeration, and then ultra cold is that much harder than freezer. So those trials are still going on. Nothing can happen until the trials are done, and we know that a vaccine has been shown to be most importantly safe, and then secondly have good efficacy, good protection against COVID. I'm hopeful, I'm hopeful within a month we may start to see some data, possibly, out of one or both of these, sort of coming to FDA, and then there would be a series of, a number of weeks, just like we've seen for the others. We cannot rush the safety part of any vaccine. But yes, part of the goal, and this is also where, like, if I knew there was another vaccine coming, I could be a little more, like we can move faster, right? And so, I am confident that there are additional vaccines that will be coming online, likely over the next 6 months, but we don't know the exact timing of that yet.
Okay, thank you so much, Commissioner.
Thank you, Alderman. And our next speaker is Alderman Rodriguez.
Thank you, Mayor Sawyer. Appreciate your leadership on this. And Commissioner Arwady, also appreciate you and your team, particularly Alfonso, very communicative with us. Happy that's been in place, and you've just been steadfast in your leadership. I just want to congratulate you on that. No one ever agrees on everything, but I certainly see your passion and your interest for our city, so I just want to commend that wholeheartedly. Just a couple questions. I think most of my colleagues have hit most of the issues. And the issue of equity, it's something that, I know we talked about even before the vaccine there was a real plan, even in the early stages. We knew that disproportionately those in congregate settings, seniors in congregate settings, and healthcare workers we're not going to be disproportionately youth. So, in my opinion, we've got a lot of catches, particularly when a community has been hit so hard by the virus. It pains me to see the data, and the relative impact on the Latino community, and the relative lack of vaccination in the community so far. Now, we know there's reasons for that, but I still think in the long term it's unacceptable. We've got to do our best to address that. And I know you're committed to that. So I think the proof is in the pudding. We've got to work together to make that happen. So with that said, my community, parts of my ward are in the Protect Chicago Plus programming. Been doing a lot of work about setting up COVID-19 testing in our ward, particularly in the village part of the community, but then also in the 606, 32, and 38 zip codes that I also have small parts of that have been disproportionately impacted late, maybe the second wave and moving forward. I'm just curious if you can paint a picture. We've negotiated, or not necessarily negotiated, but we've been able to work with several entities to do drive-through testing, indoor testing on the weekends. We've expanded just what CORE's been doing, and CORE has been great. But we've gone above and beyond that here in our neighborhood. I'm just curious, at the height of vaccination, sometime in the future, when we are getting to big numbers of people being vaccinated, how does that look compared to the way testing looks right now? I'm just curious. Some of the providers that we're working with have talked about bringing down vaccine for broad distribution, and I'm just curious about how that might look in the future.
Yeah. Okay. Lots there. So, first of all, although you didn't notice specifically, I think it's worth saying that one of the reasons why we are particularly focused on not just 55 plus, but these essential worker groups in 1B, and wanting to make sure that we kind of don't lose track of it in the span of all the older Chicagoans taking the vaccine, is that Latinx are underrepresented among 65 plus here in the city of Chicago also. So although Latinx about 29% of the city overall, only about 20-21% of the people over 65. And so that is another piece that we are working on. We don't see that issue particularly for the other race ethnic groups, but we do see it for Latinx. And the other thing about Latinx is that it's been a lot of younger people, right, who have been hit. The whole outbreak has skewed younger in that population, partly because of the essential workers. So we feel strongly about, the need, as we're kind of balancing all these things, part of holding on to that sort of, here are the groups that are in this 1B, what do we do to make sure that vaccine is going sort of in an employer-based way to these settings that have been hardest hit, is about keeping, pushing additional vaccine, in that way. I think where I think about what does this kind of look like down the line, I do want, one thing to note, unfortunately, is that vaccine is requires a lot more, it requires a lot more medical oversight than testing does. Only licensed healthcare professionals, and not just any healthcare professional, nurses, there's very specific training that you have to do to be allowed to give a vaccine, period. And there are a lot of technical pieces to it, at least with the vaccines that we have available right now. You have to dilute the vaccine a particular way. You have to divide up the vials a particular way. It is more complicated just from a medical standpoint, and we have to make sure that the appropriate people with the appropriate training, especially around this concern about post-allergic reactions. So I want every vaccinating site, at least right now, while it is still a major concern while we're learning about it, you've got to make sure you have the right medications and the people with the right training and the space for observing in the unlikely event somebody has an allergic reaction. So it is a little bit more complicated in terms of being able to roll it out very broadly than testing has been. So what we're imagining is that on the one hand, again, the heart of this is where there are existing vaccinators, do everything we can and in communities where we see lower vaccine uptake, to get those folks enrolled, and then to, as necessary, over distribute vaccine in those settings as long as there's demand to kind of keep it across the city. And then in terms of we start at this mass vaccination level. Again, right now it's about getting a lot of people through. The work of the Protect Chicago Plus, this is where, again, we're imagining kind of door to door to door. Like I was explaining to Alderman King that, an individual healthcare worker sort of gets you're ready for a slot, like let me see where it's available. It'll be the same idea down the line. And so a healthcare worker, most ideally, Protect Chicago worker, our contact tracers, et cetera, will be able to say, here's somebody who's over 65 right now. Here's an essential worker. Here's somebody. Let me help you get registered right now for a vaccine appointment. And sort of some of that like soft touch. And then a little further, there are, particularly as the weather warms up again, more ability to be able to do the biggest gap right now in terms of moving people through is actually this observation time. And we're trying, is it a good idea to have drive-through vaccine and have cars lined up and have people walking around and tell them to honk their horn if they're having a problem? We feel a little hesitant about that right now, just based on concerns about allergic reactions, etc. I think a couple months from now, there will be a lot more clarity around, with millions more people vaccinated, how much of a concern is that? How can you make sure that you're sort of ensuring safety around this while having it? We've talked about everything from turning whole streets, Columbus Drive, into large kind of drive-through and set them up and think about what that looks like, to small, bringing vaccine into communities where we're seeing lower uptake. Certainly this idea of incentivizing community-based organizations to help register people for vaccine, and we'll bring vaccine to you. You get 100 people registered, you tell us where, as long as the space is big enough, we'll bring vaccine and we'll fund you for that work to do it. Will be, I think, some of the work a little bit down the line. So it'll be a mix. But
it's just utterly frustrating to think about some of these issues and the bottleneck that we've had from the federal government in the previous administration. And if it's up to me, we have these massive vaccine events where folks can just come and take care of their business. However, I get the medical issues after the conversation. As a matter of fact, when I started this conversation at the beginning, I wanted to ask you for timelines. I wanted to know, when is this group and when is that group going to do this and that? And it's utterly frustrating to know that we're not going to get there, right?
Not yet.
Not yet, right? And by the way, I'm not blaming you, right? I think the federal issue and it's a bottleneck at that rate. But so we'll continue to talk about timelines and we'll continue to talk about saturating communities like mine, because my entire ward is just, we just been hit so hard by this damn pandemic, and it's real tough for me to think about the fact that we will continue to be inequitably serviced when it comes to the vaccine. Just a couple of very quick questions now. Homeless population, I haven't heard that. Where are they?
Yeah, planning's happening for them in 1B. They're in our congregate settings that are non-healthcare. So they're right in there, and we're planning. And again, it'll start with that sort of shelter-based for both people working in those settings as well as people who are taking advantage of some plastic conversations. But yeah, they are prioritized in that non-healthcare population.
And I just had more questions about Protect Chicago. We'll get into that in our weekly meetings with folks. But I think that's it for now. The only other, I just wanted to add that I also see issues with frontline workers, in my opinion, like library workers, like teachers, who we've talked about it, and not surprised. I wish we could vaccinate all teachers and then have schools open, right? To me, that makes a lot more sense. We're at where we're at. We'll have that debate at some other time and place. A lot more work to do. I'll just leave it at that for now. Thank you, Chairman, and thank you, Commissioner.
Yeah, thank you.
Thank you.
Can I just add very quickly one thing on that? Is that we have it has been interesting to us that we have not necessarily seen a correlation between hardest hit and high acceptance of vaccine. And so working on that sort of now and early, again, that demand piece, I think we're learning about that. And it was a real surprise to us, honestly, that there was less interest than we expected in the long-term care facility.
I would say I'm not surprised by that at all. I think about particularly when the African American community that I represent, when I go out there and talk to them, they're pointing back to the Tuskegee Airmen.
Right.
They were using guinea pigs. I mean, Latinos in this country, I represent the highest proportion of the undocumented in the Midwest United States, and ask folks if they want to go and interact with the government on anything, right? So I'm not surprised by that. We have a mountain to climb when it comes to this issue. And I think you're right. We need to get out in front of this as far as messaging. We're doing our best to the extent that we could help message that. I've had conversations direct with the mayor on that as much as 3 months ago on that issue. So to be continued. Thank you.
Thank you, Alderman. Last speaker is Alderman Vasquez.
Thank you so much, Chairman. Thank you, Dr. Arwady. Nobody envies you, but we're really glad that you're doing this. I've got a number of questions, and I apologize if some of them have already been asked. You can literally already been asked to keep moving. As far as the mutations and strains that we're hearing about, is there any chance at all that a vaccine would be ineffective because of a mutation that's coming? And also, what is the city doing to identify the new strains being found in the U.S.?
Already asked, but I'm sorry. Go ahead.
Okay.
No, I'm serious. No, go ahead.
On the first part, there have not been any variants identified at this point that vaccines will not work against. I can't promise that would never happen in the future, but it is not a high concern at this point. And the city, I actually didn't say this part, but we are actually, even before this variant was identified, we had used some of the initial funding from the federal government to increase our ability here in Chicago to do more of that molecular type testing. We put out an RFP. Our academic centers do this and upload it on a regular basis. But Rush won that RFP for $3 million to be our sort of coordinating molecular group. And so they have more than, that contract is happening. And so they will basically help coordinate among the academic centers to do this kind of more specialized testing, do some biobanking, track of this, do some of the bioinformatics work. Again, we're trying to use this to get past COVID, but also build the capacity as a city to be more ready for whatever's coming and build structures that will take us beyond. So that is something we've done.
And kind of along that, I would imagine, I think some of the answer some of it, but even after, let's say, the whole city's vaccinated, we get to that point, looking at some of the Asian countries with SARS hit, it's fundamentally changed their society, period, after, as far as precautions. So, do you think there's a time we actually take masks off, or is it hey, we saw this, but that doesn't mean you need to just let your guard down because we never know what's next?
I do think there will be a point where we stop recommending the use of that. I absolutely think that. I do think, though, to your point, this has changed us. I think there will be down, you look ahead a year or two, more sense that if people are sick, they should maybe stay home, as in coffee gets spreading their germs all over, and or they should wear a mask, right? Which is actually what we see in Asia, more mask wearing when people are sick. We're going to probably see some more of it. But I do think, I absolutely think we will get to a point when we have high vaccine uptake here that we will no longer be making that recommendation.
And so, as far as testing itself and vaccination, I think about when HIV/AIDS first really was played, and the amount of communication and awareness that government get tested, get vaccinated. I know we had gotten some attachment to an email, but what other efforts is the city doing to mass communicate that to people?
Yeah. So it's been a mix of things, and it is. When we get the money, we do have plans to spend actually tens of millions of dollars sort of on this. Radio takeovers, the TV, in a lot of this more stuff that you actually do need to pay for. We're doing, right now, a lot of the things that we have available that are more low cost, whether that's the social media stuff or the billboards that the city has, trying to do a lot with our existing partners and pushing things out. But and I'm not sure if you were on when I was talking about this, but we do have 5 separate channels with, again, did an RFP, Chicago-based communications firms with expertise in different areas who have a lot of planning. And also, I do think at the federal level, they're going to get serious about this. Like we need a real, the beer company, we know, it is not a mystery how to do this, but you got to do it. And there's not been a lot of interest in doing that. So I'm hopeful that there will be some real sort of more national work around this that we will then be able to supplement here locally in ways that are more specific to our situation here and here.
Okay, awesome. And I wanted to also commend you for sending us to different websites to kind of see what Disco is doing. That information is incredibly helpful. I just have 4 questions. And one I'm sure probably got asked before, so I apologize. I know that people want to see if city council is going to meet in person. We're at a 1C or below when it comes to that, right?
Well, we were talking about that a little bit actually, just in terms of and I had asked each of you to sort of.
Yep.
I am hopeful you are all feeling motivated to get this vaccine. If you're not, we'd actually like to talk to you because I want to help individually sort of feel confident about that. And I do think there will be some power in kind of doing this collectively. We've not made, it's not been called out at this point as sort of a 1B group, but there's some conversation about kind of political leaders that isn't quite fully gelled yet. So more to come on that.
Yeah, no, that's answer is sufficient, right? Because I know when we come to a city council meeting virtually, and they're like, see you next month, I'm going to be like, you guys talk through all this stuff, because we're not going to be there. So, no, thank you for that. And then, finally, I know there's a ton of information going on, and when COVID first hit, we were getting the daily briefings from the IGA of here's the next thing. I know you're doing daily, regular public Q&A stuff, but we're running around everywhere.
Yeah.
So would it be possible for us to get those kind of daily reports again as to the changes so we can inform our constituents?
Yeah, I think one of your colleagues has suggested at least trying to do a kind of a weekly written something. You're exactly right. This feels just like the beginning of COVID, in terms of all the information and all the pieces. We're trying to sort of, and we're keeping all the other pieces going. I think broadly, just sort of, I think we can commit to kind of a weekly. And I've also asked them to make sure these continue sort of, regularly, because we are getting, and appreciate the questions that we hear from you. And I want to have the opportunity for everybody to kind of hear what colleagues are asking and what it's just from an efficiency standpoint is helpful too. So I think we can commit to something weekly right now, and then we'll kind of see, weekly in terms of the written, and then these as often as we can make them happen, and putting stuff out.
And I completely understand that because it's a capacity issue, right? If you're reporting us every day, you can't handle all the other stuff. So the last thing, and if it can be provided through the chair, I had heard that you're getting people from other departments to help with capacity.
Yeah.
But so that we have a better understanding on the impact on the different departments. If it would be possible through the chair to find out, hey, you're just coming from different departments to this one. So we have a better understanding, right? We'll reach out to the departments and wonder why things might be a little slower than usual.
Yeah.
And it just makes sense to go, okay, I get it.
Yeah, and I can check with OEMC. Again, we don't anticipate this being long-term. It's sort of a 6-week kind of thing while we're waiting for the funding to come through. And we'll have the ability to staff it in other ways. But yes, you're right. There are people from across the city who have been volunteering to help staff pods and sort of do some other things. And we anticipate just actually being able to charge that work sort of back to the funding that we receive, hopefully right away. But yeah, it's a manpower issue as much as anything.
Yeah, no, you all have been working with what feels like less than a shoestring budget because of failed federal government. So I am grateful for everything that's been done in that time, and look forward to when things are replenished. Because clearly, you all have talked to the distribution. Now, the supply would be yours. That works different volumes.
Yeah.
So thank you for that. Thank you, Chairman, for hearing all of this. As always, super appreciate it.
Thank you. Dr. Arwani, before we go, I received, Alderman Burke was in the queue, and I think he's gone now. But he reached out to me and asked me to ask you this. Related to Walgreens, he said that he got information that Walgreens was already distributing the vaccine. One was in his store in his ward, and one was on the northwest side. He had received communication regarding that, and he was not aware of it, neither was I. Is there any validity to that?
So in those 250 outpatient providers that have been enrolled, there are pharmacies in there. So number one, Walgreens is our leading partner in terms of strike teams to long-term care. So Walgreens, CVS, and PharmScript are all doing strike teams. But yes, like just beginning this week, we've been enrolling Walgreens, CVS, but we've also, and again, the exact timing of when and this is where we're going to have to sort of choose a moment in time because padding, but we've been working, and this week has been getting Walgreens and CVS, but also Mariano's and Walmart and Jewel Osco and independent pharmacies, and again, reaching out, getting them enrolled, and then be distributing sort of vaccines to them. So it is just kicking off right now. And they also can really only handle the Moderna vaccine, the freezer-based vaccine. So we will be distributing. But yeah, I know we sent vaccine to a number of pharmacies just like literally starting in these last couple of days, and that is ramping up right now.
All right, great. Finally, I'd just like to say that as a black man, when the time comes, I definitely want to be part of the rollout. I think it's important. When I talk to friends, they're concerned about the vaccine, and I think if they saw more of us taking it, particularly like you said, black men taking it, maybe we can help, get people increased in the interest in taking the vaccine.
Yeah, very much. Yeah, wonderful. And I appreciate that. And I also, I am not the best spokesperson for this vaccine in a lot of settings, and I know that. So we've been working to sort of, how do we kind of get these messages and then make sure that they are sort of being translated across the city with all sorts of people, helping carry this message with all the different flavors of the system. So thank you, and I hope all of you are equally interested in being part of this when it's time.
Okay. Thank you, Doctor. Really appreciate you spending time with us today. At this time, this concludes our subject matter hearing. There being no further business before the committee, can I get a motion to adjourn by the same roll call vote as was applied to the determined quorum? So moved by Vice Chair Kappelman. Hearing no objections, so ordered. The meeting of the Committee on Health and Human Relations is adjourned. Thank you, everyone.